Great. So again, thank you all for joining us this morning for AGA's Crohn's Perianal Fistulas conference. We brought everyone together here today to talk about a multidisciplinary team approach to better patient care for this condition. Again, this workshop is sponsored by the AGA and is supported by grants from Takeda and Avovis. Our steering committee is Dr. David Schwartz, Dr. Amy Leitner, and Tina Prakash. They are our steering committee, and they're going to open up the conference with opening remarks. I'm going to introduce all the speakers right before they provide their presentations, but quickly, our session chairs are Dr. Coetzee, Dr. Jeff McCurdy, and then our presenters, Dr. Adler, Dr. Hart, Dr. Gary Jacobson, Mr. Gary Jacobson, who's a patient advocate, Dr. Kochar from Drexel University, Dr. Pinez, Dr. Alyssa Perian, Dr. Rimala, Dr. Deron Schneider, and Dr. War Savatarna. Our discussants today are Stacy Dillon, Dr. Layton, Michelle Rubin, Dr. Savoy, and Laura Wingate from the Crohn's and Colitis Foundation. We also have some industry attendees. They have been instructed to listen in, but they will not be participating. These are folks who are representing the companies who provided the grants to support this conference today. And with that, David, Amy, and Tina, if you all are ready with your slides,
yes,
we're ready for your opening remarks.
Let me try to share my screen. And the way my morning's been going, this could be a little tricky. Let's see. Can you see that? Is that working? No?
It is now.
That works.
Yes, it's not in presenter mode though.
Okay, I'm gonna do that. How's that?
Great.
Okay. I just wanted to first start by thanking everyone on behalf of Amy and Tina and myself. I know that weekends are precious, so thank you for giving up some of your time for this. And when we were approached about doing this, we wanted to assemble a team of truly worldwide experts that could really help improve the care of patients with perianal Crohn's disease. And our goal today is to really learn from each other, and after the end of this meeting, hopefully we will have a better understanding of the problem, and the ultimate goal is to generate a consensus statement that will help improve the care of our patients that have perianal Crohn's disease. So again, thank you for your time and dedication to your patients and everyone with this awful manifestation of Crohn's. And with that, we'll get started. So we wanted to first start by sort of setting the background of the problem that will sort of set the framework for the rest of the meeting. So I'll start first by just kind of talking about the scope of the problem. We know that about a quarter of patients with Crohn's disease will develop a perianal fistula at some point throughout their lifetime. One of the very promising things that has come out recently is that we're using biologics earlier in the disease course for people that have risk factors for more progressive disease. We're seeing the rate of perianal fistulizing disease come down a little bit. When I initially did the study about 20 some years ago, it was 21%, and now the most recent cohort that looked at in the post-biologic era, the rate of perianal Crohn's disease has decreased a little bit down to 14.5. So I think that gives us some encouragement that with appropriate medications and appropriate use medications, we may be able to reduce or improve the scope of this problem. This rate has been looked at in many different studies and is pretty stable across the world in the studies that have been done. This is from a recent meta-analysis that looked at the various population-based studies that have been done and found a rate of about 20%. So I think that is a true statement in that about 20% of our patients with Crohn's disease will develop perianal fistula. So it's a very common and awful problem. We know that the more distal the disease is, the more likely they are to develop perianal fistula. So maybe gives us an opportunity to do some early intervention and prevent fistulas from occurring in patients at risk. And we'll hear about that a little bit later on in the morning. And unfortunately, even though our medication options have improved, when it's been looked at, our durable fistula healing rates have really still are not where we want them to be. So I think we have an opportunity to do much better for this patient population. In this particular study of over 200 patients with 10 years of follow-up, they found that most of the patients had complex disease, as we have found in our patient population, and that long-term fistula healing was really only seen in a very small minority, 37% of patients with complex disease. So we really obviously want to be doing much better for our patients with complex perianal fistulas. And even though we were using biologics more frequently and earlier in the disease course, the proctectomy rate really has stayed fairly flat, about 19 to 20% when that was looked at in a Mayo cohort. So again, we want to do a much better job if we can for our patients with Crohn's perianal fistulas. So Amy, you're up.
Yeah, so just echoing what David just said, given that this is really a refractory phenotype, the majority of our patients are going to undergo a surgical intervention, and we'll talk a bit about this later in the morning about, what the surgical options are and what the efficacy of these options are. But just to remind us, this is really a multidisciplinary management of these patients. So as surgeons, we have to work in close conjunction or partnership with our gastroenterologists who are managing the medical side, as we try and manage the surgical side, which can often be very difficult given the varying phenotypes of perianal fistulizing disease. You can go to the next one, David. And part of the challenges with surgical therapy is there is this risk of incontinence with each of the interventions that we do. And you can click twice more, David, because there's two other figures, but the reported risk of incontinence is relatively low. It really depends on the surgical intervention that we are doing, but we are in and around the sphincter complex. So we have to be very mindful when we're doing surgery of the anatomy and how we are addressing the fistula surgically. When we do things like a fistulotomy, like that seen on the left, we should be very careful about how much muscle we are potentially cutting through. And this can vary between men and women if they've had multiple children. And so we have to be really careful when we're using a technique like a fistulotomy or a cutting seton. Even with things like a mucosal advancement flap or a lift, the incontinence rate has been described up to 10%. So that's not trivial, given that if patients become incontinent, this is really largely irreversible. And other interventions that we do for vaginal fistulas, like a gracilis flap, we also have risk of incontinence. So just to be mindful that when we are doing surgery, we have to be very careful about the surgical technique that we use. So even though this might be minor outpatient surgery, it can have lasting effects on the patients. And so that is one thing that we really take into close consideration when we're operating. The next things that we think about are the monetary costs with some of the interventions that we use. We want to make sure that when we're doing surgical techniques, that we think about what the cost to the patients are. And perhaps that's their insurance status, perhaps that's what product we may or may not be using, and if that product is approved. We do know that the cost of cell therapy can be as high as 70,000 euros in Europe. Now, this may change over time, but we just want to be mindful of both the monetary cost, but then also importantly, if you go to the next slide, David, there's also just the cost to the patient. So given that perianal fistulizing disease can be really challenging to treat and to heal, these are patients that are often seen both in the clinic, but also in the OR, also potentially in the ER. So generally, patients with fistulizing disease have a more severe type phenotype. They're seeing their gastroenterologist more, they're being sent to the surgeon. And a lot of these patients, we prepare them that they may actually have multiple trips to the OR over the disease course. If they have setons in, we may have to replace those setons. If they have setons in, we may be trying to use that as a bridge to a more definitive therapy or surgical intervention. And so we have to think about the morbidity and the quality of life that really puts on the patient when we're bringing them back and forth to the operating room many times. So really difficult phenotype to treat, both from a medical standpoint, as you heard from David, and also from a surgical standpoint. And you'll hear this morning that these are challenges we face with our patients. And it will be good to hear from Tina really about the patient perspective on this and kind of setting the stage for the morning.
Thank you so much, Dr. Schwartz, Dr. Leitner, and the AGA and Knighton Health. It's an honor to work with you all and to be really honing in on an important aspect of this disease that, you know, used to never be talked about. And I'm glad that we're able to sort of shed light on it today and, you know, decide on how to move forward. So as Dr. Schwartz was explaining, there can be a pretty high percentage, varying rates, of course, but this is a huge unmet need that IBD patients do have when they do develop perianal disease. It is very hard to diagnose and treat, as Dr. Schwartz, Dr. Leitner just went over. The one thing I also wanted to highlight is many patients will have a perianal fistula or several of them even before diagnosis of Crohn's disease. Trying to get a diagnosis or even being referred out to a GI, a colorectal surgeon to, you know, work that patient up is usually a challenge in different parts of this country, especially in more rural communities and across the developing world as well. As you all know, there really aren't any medications at this time with the primary endpoint of treating CPF. I realized that there was a stem cell trial in consideration that didn't meet endpoints, and for patients like myself, it was extremely, extremely disappointing because we just absolutely need more options. And as you all know, this is usually a clinical trial exclusion criteria. It was for me for many years, and it was very, very difficult to get the treatment that I needed. Next slide, please. So more about what I went through. And these were some of the, you know, this is kind of an overview of some of the challenges I had. It is much, much deeper than that. And I want to make sure I emphasize that today as we move into various presentations and panel discussions. You know, I started with fevers, chills, general feeling of malaise, but also nausea and vomiting. I kept developing multiple abscesses in the groin, but also on the backside and even on my upper sort of legs in the bikini line area. There was often bloody or foul smelling drainage. I didn't know what was going on. And, you know, all I could think at that time was just, why is my body betraying me like this? Why is it doing this to me? You know, the Crohn's has been bad enough. I've had so much surgery. I had a J pouch at this point because I was diagnosed with ulcerative colitis for the first 5 years of my journey. And sort of how that diagnosis was really changed was they found multiple fistulae, and then they found backlash ileitis that with granulomas that looked consistent with Crohn's disease. So it really, you know, that change of diagnosis plus the development of all these fistulae, you know, it made my head spin. It made my family's head spin. We were like, wait, we thought this disease was cured with a J pouch. That's what I had been told. Whole other conversation. But just to give you a sense, as it really turns your world upside down, I had sepsis consistently. I was hooked up via PICC line to 3 different antibiotics because I had anaphylaxis to Zosyn. So it was this constant need to be treated, just like Dr. Leitner was saying, multiple interventions. There were multiple antibiotics involved, multiple operating room visits, of course, CTONs placed, replaced, removed, depending on where I was in the treatment process and depending on which number fistula it was. And it was a very, very challenging time for me to really accept, you know, that this was happening to me as a 28-year-old woman who had just gotten married the year prior. We thought we had moved on from really the worst aspects of this disease. And now I had been faced with a brand new aspect of inflammatory bowel disease that was much worse than anything I had ever experienced before. I was having urinary tract infections, bladder infections, of course, the sepsis that I mentioned, lots of pain with bowel movements, stool passing through the fistula, and, you know, wearing diapers, wearing pads, losing that confidence or my ability to go out into the world and interact with people, because any given moment I was leaking, and I knew I was the only person who knew that was happening, and people around me didn't, but it was enough to sort of cripple my confidence. So there really was this mental health toll that, you know, I do want to emphasize today, and it is a primary reason for us to come up with solutions, consensus statements on how to treat patients, because the mental health impact takes such a deep toll on us. For me, as I was mentioning, it was like my first year of marriage, and there were a lot of challenges here. I faced, unfortunately, a lot of ridicule from my community. There was talk of, in my community, just being of South Asian descent, it was a very challenging thing to for my in-laws and my extended family to accept that this was happening. They were like, well, now, having kids is out of the question. Talk towards my husband saying, is this a life that you want? You can still get out of this. These were things that I was facing, and it made me feel less than human. It made me feel less than a woman. And I can't emphasize that enough today. We need to focus on CPF when we are thinking of treating patients, both from a physical perspective, but also from a mental health perspective. Thank you all for being here today and for joining us. With that, I'll turn it over to Knight and Health to move us along. This is for later on in the...
Later. Okay, very good.
Okay, so David, if you guys are all set, sounds like you're all set, then we can move into the first session. All right, great. So we'll start our first session. Let me quickly introduce you to our session chair, Dr. Jeff McCurdy. Dr. Jeff McCurdy is Assistant Professor of Medicine, University of Ottawa Clinical Investigator at the Ottawa Research Institute. He's co-chair of IBD Update and co-editor of the journal IBD Today. His research interests focus on identifying predictors of disease-related outcomes in IBD, and including perianal Crohn's disease, infectious exacerbations of IBD, and venous thromboembolism. Dr. McCurdy is our session chair, who will also be moderating the conversation when we get to the group discussion. Our first presenter is Dr. Perian. So I'm going to introduce you, and then you may want to get your slides ready to go so that you can jump right in as soon as you're ready. Dr. Perian is an Associate Professor of Medicine at Johns Hopkins University, and her research focuses on Crohn's perianal fistula and emerging endoscopic technologies for the treatment of Crohn's disease and ulcerative colitis and their subsequent complication. She has presented 3 oral presentations on her research at Digestive Disease Week and numerous poster presentations. She works closely with basic scientists to advance the treatment options for patients with inflammatory bowel disease. Dr. Perian, whenever you're ready.
So as long as I could figure out how to get myself off mute. I'm sharing the correct screen, correct? Yes?
Yes.
All right. Well, thank you everyone for the invitation to be part of this just amazing group and to present this morning. I do apologize for my voice. I have woken up with whatever the elementary school illness of the week is. So excuse me for that. I'll be discussing the etiology of Crohn's perianal fistula. This may be the topic we have the least amount of concrete data on, but I hope to show you what's been discovered really thus far. As for an outline, a quick introduction, talking about how inflammation plays a role in Crohn's perianal fistula, talking about the main driver of fistula, epithelial to mesenchymal transition that occurs in these cells, the role of the microbiome, some genetic associations, and then a quick summary at the end. So when we look at the etiology of Crohn's perianal fistula, we really look towards the etiology of Crohn's disease itself, which we know results from a dysregulated mucosal immune response to microbiota in the intestinal mucosa. And Crohn's disease is characterized by an altered response of both the innate and adaptive immune cells and an increase in inflammatory cytokines. And all of these factors are thought to play a major role in Crohn's perianal fistula. The pathogenesis of Crohn's perianal fistula is separate and distinct from cryptoglandular non-Crohn's fistula, whereas Crohn's perianal fistula are caused by penetrating abscesses and or inflammation into adjacent skin, and they may initially present as an abscess that upon spontaneous drainage evolves into a fistula tract. As you can see in the picture here, also typically involves luminal inflammation, although not always. And that is different and in contrast from cryptoglandular fistulas that tend to originate from kind of an infected or inflamed anal crypt gland, as you can see in the corresponding picture there. So this diagram reviews the proposed pathogenesis of Crohn's perianal fistula here on the left, with this epithelial barrier defect, as you can see here, leading to spillage of the microbiota and inflammatory response. And on the right, you see a cryptoglandular fistula with an infected anal gland here and no true epithelial defect. And there's a slightly different inflammatory response, lacking MMPs and IL-13, but actually higher rate, as you can see here, of the macrophages. So the pathogenesis of fistula formation in Crohn's is multifactorial, and albeit not fully elucidated, with several pathophysiological elements that may contribute to fistula formation. We know chronic inflammation triggers this epithelial barrier defect, which then allows the invasion of microbiota and cytokines, as we just saw. Elevated TNF levels induce an epithelial to mesenchymal transition, allowing these intestinal cells to penetrate deeper into the mucosa and leading to localized tissue damage and connection to other organs and skin. And we'll talk about each of these steps in just a tiny bit more detail of what we know. So first, to jump into the inflammation aspect. What are some of the drivers of inflammation in Crohn's perianal fistula? Many of them are similar to Crohn's disease itself, and some a little different. We know that CD4 cells appear to be crucial to the development of Crohn's perianal fistula. And studies have shown increased CD4 to CD8 ratios. And in addition, CD4 and CD161 T cells have been shown to accumulate in Crohn's disease fistulas. And when treated with a local anti-TNF therapies, this has been shown to decrease. And this is not surprising, as we know anti-TNF plays a major role and is a major treatment in this. Crohn's perianal fistula have higher lymphoid cell predominance compared to cryptoglandular, which are more of a myeloid cell enriched process. And there's alterations in the cytokines. There's variation, what you could see on different studies. Here I put some of the similarities amongst all the studies that are agreed on, with this increase in TNF alpha, IL-1 beta, interferon gamma, IL-8, 6, and a decrease in IL-17A, all thought to lead to increased levels of inflammation. So let's talk about how this relates to epithelial mesenchymal transition, or EMT, in Crohn's perianal fistula. This is thought to be triggered by those inflammatory cytokines that we just described. And EMT is a cellular process during which epithelial cells acquire mesenchymal phenotypes and behavior following the downregulation of their epithelial features. So what happens is the cells lose some of their epithelial properties, including their cell polarity and cell-cell adhesion, and they gain some of those mesenchymal characteristics, including migratory and invasive properties. Now, EMT is a physiologic process and involved in embryogenesis and tissue repair. However, it can also be pathologic, as we see in cancer and fibrosis. So how do we know this transition is happening from an epithelial to a mesenchymal cell? Well, on a cellular level, they've looked and they find that these intestinal epithelial cells covering the perianal fistula tracts compared to normal IECs have decreased expression of E-cadherin, increased levels of TGF-beta and beta-6 integrin, which all suggest mesenchymal changes. And these cells are transition cells at this point, and they still retain some of those epithelial markers, such as cytokeratin 8 and 20. And important to note here is this is a fluid reversible process in which these cells can turn back to epithelial cells with tight junctions, again, based on signals received from the microenvironment. So if we can alter that microenvironment and downregulate those inflammatory cytokines, there is that potential of reversing the process. TGF-beta is an important thing to mention here, as it's thought to be the main inducer of EMT. It regulates many EMT-related cytokines and transcription factors, and it induces IL-13 expression, which is known to play a major role in cell invasion in Crohn's perianal fistula. TNF-alpha is in high concentration both in the inflamed rectum and the fistula samples, and can induce EMT in these IECs, and can also induce expression of TGF-beta, which, as we just mentioned, is that main EMT regulator. And it's been shown that CD3 T cells are the main source of this TNF-alpha in Crohn's perianal fistulas. And lastly, we have to mention the matrix metalloproteinases, or MMPs, especially 3 and 9. These have really high expressions in Crohn's perianal fistula tracts. They're known to enhance extracellular matrix degradation, release growth factors. They induce EMT and stimulate fistula formation. And they're kind of involved in multiple steps because the mesenchymal cells secrete them, but they also induce further EMT. So a switch over to the microbiome. This again, data is varied between studies, and some of them kind of contradict each other, but some of the commonalities here is that patients have different bacteria found in the fistula tracts potentially as compared to the stool. And so a few of them here is the Achromobacter and the Corynebacterium are increased, with the Bifidobacterium slightly decreased in the tracts compared to the fecal samples. The murmel dipeptide, which forms the cell wall of most bacteria, could stimulate the expression of EMT-associated genes and drive that EMT process. And this suggests that bacteria could start EMT to provoke an immune response and play a role in Crohn's perianal fistula pathogenesis via several different pathways. So you could see it could stimulate the inflammation, which would then lead to EMT, but it can also lead to EMT directly itself. Several studies have actually found a paucity of bacteria within the Crohn's perianal fistula. However, peptidoglycan, which is a major component of the bacterial cell wall and known to stimulate inflammation, has been frequently found within Crohn's perianal fistula, implying that even once we destroy the bacteria, the cellular remnants remain and continue to drive an inflammatory response within that fistular lumen. And as we know, antibiotics improve symptoms, but they do not lead to that long-term healing. And so although bacteria may drive and play a role in this inflammatory process, other factors must be involved. The last topic I want to touch on is genetics. So a number of genetic associations with perianal fistula and Crohn's have been identified, and I want to point out just a few of the main ones. The IL-10R mutation, as we're maybe familiar with, predicts that early onset and severe form of Crohn's disease with ubiquitous perianal disease. And we know what IL-10 does. It's known to inhibit TNF-alpha, maintains immune homeostasis of the GI tract. So not surprising that a mutation in there is going to lead to a Crohn's phenotype. Specific NOD2 mutations have been associated with Crohn's perianal fistula. And of course, NOD2 protein is important in the innate immune response. IBD5 mutation creates impairments of the carnitine organic cation transporter, which alters bacterial handling and leads to intestinal inflammation. And the immunity-related GTPase family M, or IRGM, which is part of the autophagy pathway, which eliminates intracellular organisms, has been shown to have a role in the development of Crohn's perianal fistula as well. So in summary here, chronic intestinal inflammation resulting in an abundant secretion of cytokines such as TNF-alpha, TGF-beta, together with epithelial defects contribute to EMT. The microbiota and its remnants are thought to participate in both inflammation and EMT, and the activated MMPs lead to further tissue damage, inflammation, and fistula formation. There are some genetic mutations that have been identified, especially in early onset IBD associated with Crohn's perianal fistula, but not surprising, further research is really needed to better understand each part of these processes to lead us to better therapies and eventual cure. Thank you very much.
Thank you. Our next speaker is Dr. Jeremy Adler, who is clinical professor in the Division of Pediatric Gastroenterology at the University of Michigan and serves as the interim director of the Susan B. Meister Child Health Evaluation and Research Center. Dr. Adler's clinical and research interest is in the care of children and adolescents with Crohn's disease and ulcerative colitis. His research focuses on improving short and long-term outcomes and health-related quality of life for children with IBD. He's been working on developing evidence-based strategies for preventing disease-related complications such as fistulas and pouchitis, and to mitigate disparities among children with IBD. Dr. Adler, when you're ready.
Thank you. Let me also just try and share my slides. Can you see this?
Yes, we see them.
Yes, okay, great. Thank you. Thank you very much for the invitation. This is a really exciting group and really very, very important. So I'm going to talk about the risks of progression to and developing perianal fistulas. These are my disclosures and the objectives. So there are a number of risk factors that have been described for perianal, developing perianal fistulas. We're going to review the evidence for many of these, but as with the previous presentation, as Dr. Perian said, there's not a lot of evidence for a lot of this. So one of the more common things that we talk about is the age at diagnosis being itself being a risk factor for perianal fistulas. And in much of the literature, there's descriptions of younger patients having a higher likelihood, or at least people with a younger age of diagnosis having a higher likelihood of developing perianal fistulas. But if you look in the pediatric literature, it's actually the opposite. It's the older patients. What I think is going on here is that there's a peak incidence of perianal fistulas in the teenage years. And younger children, with the important exceptions of some of the infantile Crohn's disease, don't have nearly that rate of perianal fistula development. There are a number of studies that have indicated that race and ethnicity are associated with perianal fistula diagnosis. These studies on the left are single institution studies, each of which have shown higher rates of perianal fistulas in African Americans, Hispanic, Asian patients. And on the right is a large multi-center pediatric cohort, the Improved Care Now network, that essentially found the same, and non-white here included Black, Asian, and Hispanic patients. But not all studies have shown this. This is a single institution study from Ray Krause's group that did a really nice adjustment for patient characteristics and other confounders. And after those adjustments, didn't find an increase in disease complications, and this included perianal fistulas as well. One of the problems we have with the large-scale studies using administrative claims databases is there hasn't been a validated case definition. So we did a study comparing medical record review to administrative claims. This is billing code data, and found that the billing code for perianal fistula underrepresents perianal fistulas. And if we have a composite definition, where we do a better job of capturing those patients. We used this definition in one of those large national claims databases, Optum Insight. This is patients with private insurance. And this is a study where we looked at patients aged 5 to 24, excluded everyone who had perianal fistulas at the time of diagnosis, and did a propensity score matched analysis. This sort of levels the playing field, so we're comparing like patients to like patients. And we evaluated what are the risks for developing perianal fistula. We found after all these adjustments that there's no differences in the rate of perianal fistula by race, no difference by household income, but there was a difference by education. So patients who came from families with higher educational attainment were less likely to develop perianal fistulas. Excuse me. So maybe it's not race, maybe it's more the social determinants of health. There are a few studies that show, there are a number of studies that show there increased disease complications in patients who have a longer time to diagnosis. The findings with perianal fistulas are more inconsistent, I think mostly because they're not looked at as much. But these are two studies that have shown, both in the US and in Switzerland, that the longer you wait before diagnosis, not that somebody's waiting, but the longer that there's a delay before diagnosis, the higher risk of perianal fistula at diagnosis. It makes sense. If long-term disease without treatment, it's going to get worse. Excuse me. So I think undertreatment is an important thing to consider. This is now getting to be a dated study from the Olmsted County registry, showing that treatment of patients with Crohn's disease with mesalamine, with 5-aminosalicylates, is associated with a high rate of disease complications. And this is essentially a surrogate for undertreatment. And in that same large national claims database, we found exactly the same thing. Here, SST, steroid-sparing therapy, is immunomodulators and biologics, basically everything we think of nowadays as standard medical therapy. And if a patient does not receive early steroid-sparing therapy, there's an increased risk of later developing perianal fistulas among people who didn't have them at the time of diagnosis. Excuse me. Proctitis and strictures are both a setup for developing perianal fistulas. This makes sense. If you have severe proctitis, there's a lot of inflammation. You can get it's the right environment, as Dr. Perrin had described, for fistula development. This was a study that actually looked at patients with and without perianal fistula, without proctitis. And proctitis itself was associated with a 4-fold increased risk of perianal fistula. And anal rectal strictures is a real setup, because that sets up essentially a high pressure zone. And if the luminal contents, and in this case the stool, can't get through a narrowing, and if there's a mucosal inflammation, it's going to take the path of least resistance, essentially. So what about other patient characteristics and features. So skin tags and fissures are often thought of as harbingers of perianal fistulas. This was a study that followed patients forward in time who had perianal fistulas and strictures at diagnosis. I'm sorry, perianal fissures and skin tags at diagnosis, and found that they had more developing. But it's always been a question how much of this is just a fistula that was already under there. And this study really nicely demonstrated that these patients had MR enterographies done at diagnosis, and this was adults and children, 600, almost 700 patients. And they found among patients who had Crohn's disease but did not have a perceptible fistula at diagnosis, so no symptoms, nothing seen on exam or endoscopy, nearly 1 in 5, 19% of them had a perianal fistula, tiny little fistula or a sinus tract on MR imaging. These are subclinical fistulas. And these matter because if you have a subclinical fistula, they found that there was a 3-fold increased risk of later developing a clinically significant fistula, symptomatic fistula, abscess, if those subclinical fistulas were there already at diagnosis. We were interested, apart from that, do skin tags and fissures have any prognostic value? So we looked at, in our institution, everybody gets a MR enterography with perianal fistula protocol at diagnosis. So we partnered with our radiologists and had every one of the MRs reviewed to exclude patients who did have those subclinical perianal fistulas. And of course, we found about the same had them. But after you exclude those with subclinical occult fistulas, skin tags and fissures, the patients who had skin tags and fissures but no fistulas, about 20% of them went on to develop perianal fistulas compared to only 4% without. And after adjusting for time and other patient characteristics, this is about a 6-fold increased risk of perianal fistula development. So this seems to be a real prognostic indicator for risk of perianal fistula. Granulomas are thought of as one of the hallmark features of Crohn's disease, but of course not everybody has granulomatous inflammation. There have been a number of studies that have shown that granulomatous inflammation is associated with the increased risk of disease complications. It's really hard to tease it out sometimes because you can develop granulomas as a response to injury, foreign body reaction, things like that. We looked at that same cohort of patients where we had already ruled out the perianal fistulas and had the pathologists re-review the biopsy slides because we wanted to exclude crypt rupture granuloma and things like that. And once you have a clear cohort of patients with granulomas who do not have perianal fistulas yet, the presence of granulomas is associated with a 3-fold increased risk of later on developing perianal fistula. So this may also serve as a prognostic marker as well. I thought Dr. Perrin did an excellent job describing the microbiome, and there's a lot of variation between studies. And it's really hard to tell how much of this is causal and how much of this is an epiphenomenon. And it's hard to rely on the microbiome to predict risk of perianal fistula development in people who don't yet have them. And the same is true of the antimicrobial antibodies, CBER, ANCA, ASCA. There seems to be some relationship there, but not enough evidence to really discriminate who is and is not at risk of developing perianal fistulas. And the genetic mutations as well. I think it's an exciting field and there's a lot of interesting research going on there. But aside from the IL-10 receptor defects, which is associated with neonatal Crohn's, and typically you already have fistulizing disease before you even know this mutation is there, or multiple mutations, that genetic profiles aren't yet at the point where they can help us predict patients with perianal fistulizing disease. So I want to just finish by mentioning briefly what Dr. Schwartz had mentioned, is that I think there's an opportunity, or alluded to, there's an opportunity for prevention. Many of the newer studies have shown that early treatment might be associated with a reduced risk of perianal fistula development. This was a study I mentioned earlier. This was a study done by Dr. McCurdy, which essentially found the same thing, that early use of anti-TNF drugs and possibly ustekinumab is associated with low risk of perianal fistulas. And these are studies in our pediatric population showing that early treatment, particularly with anti-TNF medications, is associated with a reduced risk of developing perianal fistula. So if we could prevent these, I mean, that would be terrific. So in conclusion, there are a number of risk factors with varying degrees of evidence supporting them. The strongest evidence is for proctitis strictures, skin tags, fissures, and granulomas. I think a lot of what we think of as the patient characteristics that are assumed to be biologic may not be. They're more likely the social determinants of health leading to diagnostic delay, treatment delay, undertreatment, which is really a setup for complications. So I think the key is to identify patients early and treat them well. And I'll stop there. Thank you.
Thank you, Dr. Adler. We'll now hear who should be screened for CPF from Dr. McCurdy. Dr. McCurdy, when you are ready.
Okay, can everyone hear? Okay,
Yes.
perfect. So I'd like to thank the organizer, and also a big thank you to Tina for your story. I know it can be quite difficult, and as busy clinicians, we often don't get the time to, really hear the patient's full story and how it impacts quality of life. And so it's really sobering when we get to hear that. So I've been tasked with a discussion on who to screen for perianal Crohn's disease. And again, I think maybe the theme of this conference today is that a lot of these talks have very little or incomplete evidence to help support. And so it will be interesting to see what all of our colleagues online today think. So what I thought I would do is split this talk into two sections. And so the first is when to screen for perianal fistulas in patients with established Crohn's disease. And for this part, I'm not going to talk as much about the different modalities, imaging modalities, because this will be covered in other sessions. And then the second part of the talk is something that maybe our surgeons see more of, but when is to assess for Crohn's disease in patients with perianal fistulas. So two very different clinical scenarios. So we've already seen this. This is the most recent meta-analysis. This included population-based studies looking at the incidence of perianal fistulas in patients with established Crohn's disease. And we've already heard from David and others that the 10-year cumulative incidence of perianal fistulas is 20%. Keep in mind that these were population-based studies, and as Jeremy nicely pointed out, administrative data will underestimate the proportion of patients with perianal fistulas, unless you're using case definitions that combine multiple techniques, which were not done in this study. The other thing that I wanted to point out is if you look at the 1-year incidence of perianal fistulas in this population, most patients who will develop perianal fistulas do so within the first year. So if we're talking about screening, this is a critical time point. Patients need to be screened early on. And so who do we screen? There's in consensus guidelines, there's really little that's ever mentioned about who to screen. But I think given the prevalence of perianal Crohn's disease in patients with Crohn's disease, I think that a meticulous physical exam of the perineum should be performed for all patients at the time of Crohn's disease diagnosis, particularly in that first year, and as well as any time a patient develops perianal symptoms. So as a Canadian, a shout out to our Canadian consensus guidelines. They also recommend strongly that all patients with suspected perianal fistulas or abscesses undergo either an MRI or an ultrasound. But I guess the question is for the group, is this enough? And should we be doing more? And so what I mean by this, patients without symptoms of perianal fistula or abscess, even those with the normal perianal exam, should we be screening by MRI or EUS in higher risk patients? And so Jeremy pointed out a number of the characteristics that would lead you to higher risk, say Alyssa as well with the genetic determinants, so patients with rectal involvement with deep ulcers, those patients with fissures, tags, should we be doing supplementary MRI imaging in this population? And this was really brought forward by this study that was published in CGH in 2020, which demonstrated that patients with Crohn's disease can have subclinical perianal fistulas. And so this was a study with Korean adults. So there were 440 consecutive Korean adults who were undergoing an MR enterography for either established or suspected Crohn's disease. All of these patients had no evidence of perianal fistulas on physical exam. And in addition to the MR enterography, these patients also underwent supplementary anal imaging by MRI. And what they found is that among the patients who had no history of perianal fistulas or abscess, 13% of these patients had subclinical perianal fistulas on imaging. And as Jeremy nicely pointed out, that among the patients who had subclinical perianal fistulas, these patients had a 3.5-fold increased risk of developing future symptomatic perianal Crohn's disease. And so, these are small studies. They haven't been replicated in multiple patient populations. So I think this is a discussion for the group is, should patients without symptomatic disease and without evidence on a clinical exam of the perineum, should they be undergoing supplementary perianal imaging? So I'm going to shift focus. And so a difficult clinical conundrum, and that is, how do we differentiate Crohn's disease from cryptoglandular fistulas? And so I think with patients who develop their first perianal abscess or fistula, the question, should all of these patients be assessed for luminal Crohn's disease? And so if you look at the guidelines from ECHO and ESCAR, they do recommend that an ileocolonoscopy followed by a capsule endoscopy when the endoscopic evaluation is negative for all patients with unexplained perianal abscesses or complex fistula. The issue is that we know that cryptoglandular fistulas are much more common than Crohn's-related fistulas, and some series have suggested that they're tenfold more common. And so with this in mind, is it our best use of our resources to screen everyone? Does everyone require an extensive evaluation for luminal Crohn's disease? Or can we have a more rational approach and predict those patients with that are at higher risk for having Crohn's disease, selectively investigating or screening these patients? And so there has been a bit of work. So this is a diagnostic accuracy systematic review and meta-analysis. And I'm going to present the most robust findings. So there were a number of imaging characteristics that were more common in patients with perianal Crohn's disease rather than cryptoglandular fistulas. And so on MRI, rectal inflammation, multiple branch fistula tracts, and abscesses were highly specific in distinguishing perianal Crohn's disease from cryptoglandular fistulas. However, the sensitivity of each of these values or each of these parameters when used alone was quite poor. And so the same thing occurs with ultrasound findings. So there's the Crohn ultrasound fistula sign. If there is fistula debris within the tracts and fistula bifurcation, so maybe not surprisingly, each of these characteristics had high specificity at distinguishing between perianal Crohn's disease and cryptoglandular fistulas. But again, the sensitivity was quite low. So the take home from this work is that if these characteristics are positive, then you really need to go on and look for luminal Crohn's disease. But if they're negative, I don't think that these tests are sufficient to exclude luminal Crohn's disease. So this was an interesting study looking at fecal calprotectin. They included patients with Crohn's disease. There were 37, and then 19 patients with cryptoglandular fistulas. And not surprisingly, the median concentration of fecal calprotectin was higher in patients with perianal Crohn's disease compared to cryptoglandular fistulas. And they found that the diagnostic accuracy of fecal calprotectin was excellent. It was the area under the receiver operating characteristics curve was 0.9. And if they used a cutoff of 150, this had a sensitivity of 81% and a specificity of 89% in distinguishing between perianal Crohn's disease and cryptoglandular fistulas. Just keep in mind that in this study, these were patients with established either Crohn's or cryptoglandular fistulas, and it doesn't necessarily represent the patient at their first presentation of a undifferentiated perianal fistula. And then, so finally, this is a study that we recently published in JCC, and we included 45 consecutive patients with isolated perianal fistulas. And so we defined this as patients who underwent a negative ileocolonoscopy and cross-sectional imaging of the abdomen. And we looked at patients who had undergone video capsule endoscopy, and to give us kind of an idea of the baseline rates of findings in the general population, we used 90 age and sex matched controls of patients who were undergoing video capsule endoscopy for other reasons, so mainly gastrointestinal bleeding or iron deficiency anemia. And what we found was that in the patients with isolated perianal fistulas, these patients, 26% had imaging findings suggestive of Crohn's disease on video capsule endoscopy. And this was only 3% of patients in the matched controls. And so if we look at the patients who had a positive capsule test and compared these to those with a negative capsule test, we found that smokers, patients with abscess on MRI, patients with rectal enhancement on MRI, or patients with a single positive IBD serology were more likely to have a positive video capsule endoscopy study compared to those with a negative study. So if we put everything together, this is an algorithm that we proposed in one of our studies, and I'd be happy to hear what the group thinks, especially the surgeons who see a lot of these patients. So we propose that patients with undifferentiated perianal fistulas should undergo a history physical exam, a fistula evaluation by imaging, as well as fecal calprotectin. And if any of these are positive, so history of luminal symptoms or any of the other parameters, then these patients should undergo an evaluation for luminal Crohn's disease, beginning with ileocolonoscopy and small bowel imaging. For those with negative testing, then this likely suggests cryptoglandular disease. But for patients that continue to have unhealed perianal fistulas, or those that develop recurrent perianal fistulas, these patients should undergo a video capsule endoscopy study. So in contrast, if patients don't have positive findings on this initial screen, then we're likely dealing with cryptoglandular disease. They probably don't need any other investigations at this point. However, if their fistulas don't heal or if they're recurrent, then these patients should undergo evaluation for luminal disease. And again, to look for the same algorithm that we would do for patients with positive findings. So thank you. I'll leave it at that, and maybe we can start our panel discussion. People have unhealed fistulas and they've had fistulas forever. I mean, they're more likely to undergo exams under anesthesia for biopsies of the tissue tracts, whereas patients that are doing very well and have early healing of the tracts, they're maybe less likely to undergo biopsies of the fistula tracts. And so are we getting kind of a biased look? And then along the same lines, patients with Crohn's disease are maybe more likely to be treated with antibiotics. And so could this account for the absence of bacterial components, except for the peptidoglycan remnants of bacteria? So what's your thought on how well representative are the individuals are being studied of our overall population?
That's a great point, and I was trying very much to keep to time, but that was a big point to bring up, is that all of these studies are small. All of these patients have pretty much universally been on therapy and have had this long standing. So this isn't frequently, they're not a new diagnosis to look at kind of what's happening right at the beginning of things. So there are not a lot of patients, not a lot of studies. So we obviously need more information there. And they're, they've been on antibiotics, like you said, they've had surgery. Most of them have had cetons. And then in terms of the cryptoglandular ones, in terms of those studies, they have had interventions. I would say maybe not as many, because they're always looking for like that control group. So maybe not as intervened, but most of them, yes, have had antibiotics because they're undergoing a surgery. So none of these are fresh, untouched fistulas that we're looking at, which is a huge caveat.
So maybe another question, an important one from Julian. So again, Alyssa, you're on the hot seat again. So patients with, why do some patients with severe rectal inflammation never develop perianal fistulas? And maybe to expand on that, do we know of any difference in the pathophysiology between the patients who have isolated ileal disease but then develop perianal fistulas compared to the patients who do have rectal ulcers, and so is that an entirely different mechanism?
That was a good question. I saw that in the chat, and then David saved me by saying, let's discuss it as a group. So I was hoping someone would save me on that one. I mean, that's a fantastic question. And looking at all of these studies, it seems as if obviously something is missing in terms of something we are not aware of a potential different pathway, different cytokines, different risks that set some of these patients up for that. Because I think all of us, have those severe rectal inflammation that do never develop a fistula. And then on the other side, like you said, there's just no rectal inflammation. They have, awful fistulizing disease. So there must be another pathway, another group of cytokines. In my thought, that's unrecognized, but I'd be very curious what others may think about that.
So we're gonna keep you on the hot seat. Another important question from Elsa, and I think this is something that we all struggle with. And correct me if I'm wrong, Elsa, but so differentiating in Crohn's disease versus UC in patients who develop fistulas. So I'm guessing that you predominantly are referring to patients with a J pouch that then developed perianal fistulas, as per Tina's story.
I think, Jeff, it's clinically we often see patients with UC, or not often, but they can develop a fistula, and sometimes we rebrand them as Crohn's based on the phenotypic description. But sometimes we are pretty clear that it is UC. It's looked always endoscopically, histologically like UC. So quite different maybe from Tina's story, where I think something different was going on. But it's always, again, are we just defining, classifying things maybe sort of unhelpfully sometimes with these buckets of UC and Crohn's, rather than thinking in a problem sort of specific way? There's something specific to fistulas, exactly as the last discussion was about rectal involvement or not, but some patients are still getting a fistula with or without rectal involvement. So it's maybe just the terminology we're using, which is sometimes not helpful for us.
Yes, and I mean, I think that's a good point as well, as we've seen these UC patients who end up getting it. And I guess the thought is maybe it's a slightly different mechanism, in that it's the severity of the disease, and that it somewhat erodes in and into that serosal area, allowing that to occur. But I mean, I think it's a great question unknown. I would say there's definitely somewhat of a different mechanism, because as you mentioned, we see severe rectal disease in UC patients who do not go on to develop fistulas in the majority of them. So there must be a different phenotype. And, we've sometimes blamed it on maybe deep biopsies, did some deep biopsy with a mucosa that was already really poor, kind of lead to this, but sometimes they haven't had that. So, my thought is there just such severe inflammation that somehow is getting through to that serosa and then setting off almost a similar inflammatory response, leading to that penetration.
If you don't mind me chiming in, So, you're making very good points. I was sort of deemed UC for a long time. They were looking for Crohn's extensively because my father and my aunt both had Crohn's as well. And they just could not see any disease in the ileum. They didn't see, any granulomas or anything like that. And then it just completely changed after I had the J pouch sort of taken down. And even before that, I had pouchitis. So it became chronic refractory pouchitis very quickly. And then they started seeing the granulomas and the fistulae. And that's what resulted in the diagnosis change. But for a long time, they were calling it indeterminate colitis because, like you said, a lot of times it is definitively just UC. So important points. Since then, my sister's also been diagnosed, but she had skip lesions throughout her colon. So just, we're seeing a lot more Crohn's in just my family. And I think they were looking for it from the very beginning.
I think probably not in your case, it's a little more dramatic, but in some of the pouch patients, we have the back and forth with the surgeons. Is it a post-surgical fistula? And I think that's always an interesting discussion as well.
Absolutely. It took about, I think, after takedown, almost 2 years for my first fistula to develop. I know with post-surgical fistulae, they usually expect those a little sooner, if I'm not mistaken. So yeah, no, excellent points.
Yeah, this is Michelle. I was actually going to say the same thing. Sometimes it is from a leak at the anastomosis, but those do occur early on most often. The other thing is that I think sometimes, I know we don't know it's, whether it's UC or Crohn's fully, but we don't see anything that's Crohn's. However, I, also question that, when we do a pouch, we are making this pouch, which was small bowel, now holds stool. And in a patient who may have a little predisposition maybe to possibly Crohn's-like type phenotype, does that holding of stool change that microbiome in there? And over time, maybe it develops. I don't know. It's just another thought to throw out there to involve the microbiome.
Jeremy, can I go to you? Can you comment on the diagnostic delay that you answered in the chat, just for everyone?
Yeah, so to the point of diagnostic delay, so not a lot of the studies that have looked at diagnostic delay have actually addressed the question of perianal fistulas. Several studies have shown that people who have perianal fistulas at diagnosis actually have less diagnostic delay, which makes sense. You have symptoms, you're going to seek out care. But the question of how much is that delay associated with an increased risk of later developing perianal fistulas? Only a few studies have looked at that, and they have found increased risk. I think it's a problem of perianal fistulas themselves can be asymptomatic, as we were hearing earlier. And so that raises the question that you had brought up, Jeff, of how often or how closely do we need to be looking at people who are asymptomatic. And if I could comment on the previous question about the changing phenotype of disease, about something in the ballpark of 20% of people with Crohn's have isolated Crohn's colitis and fewer than half of patients have granuloma. So I think we don't always know what is Crohn's colitis. And it may simply be we don't have the easy tools to distinguish between the two. And what we call ulcerative colitis may have been Crohn's all along, but we don't have a way of knowing it.
And is there really as much of a distinction between Crohn's disease and chronic Crohn's disease and ulcerative colitis as we used to think?
Exactly.
Jeff, I'm sorry, I can't put my hand up. I don't know if I'm just missing the button at the moment. Is it all right just to say something briefly now?
I'm okay if people want to just jump in. Don't be shy.
So it's the time to diagnosis thing. So I wonder if this is one of the most significant things that this group can maybe impact on. Just to think about in a bit more detail, because I think if we could say go out to our different countries and achieve trying to get some data on this, then it can be very helpful, because then you can actually kind of do something in your own country to try and better yourself according to other people who aren't, it's sort of a ranking system almost. But if we recognize it's a problem, then try and get some data on time to diagnosis, particularly for perianal Crohn's, then we can start to actually sort of nudge in and try and ameliorate things a little bit. Just that the group knows the ECHO has recently putting forward its sort of 5-year goals. We've recently designed that, and it's called the REACH algorithm. Or REACH, it's an acronym which stands for, the R is rapid diagnosis and treatment, the E is equitable access, the A is attaining sustainability, the C is cause, and the H is holistic. But everything that ECHO is going to try and do over the next 5 years will try and actually, through its education and research, hit one of those sort of 5 things of the REACH sort of acronym. But it seems that the rapid bit is something for perianal disease we could all really, really work on. And sometimes it's just starting at the beginning, getting some data on what's going on in different countries, and then using that as the fuel to try and actually get it a bit better.
If I could add, I think that's a really important point, and getting data from different countries would be helpful. But I think there's important information to learn within countries. So I think there's another piece of the diagnostic delay that may be related to the education base of our primary care colleagues. Like people don't think of Crohn's disease when they see a patient who's not white. And I think that may play into the increased delay, increased burden of disease at the time of diagnosis among non-white, non-Hispanic patients. And we could even see that within our country or I suspect we'll see it if we look more closely.
If I also can jump in, sorry to go there without raising my hands because I don't see the button as well. So I do believe that the diagnostic delay, of course, will vary from regions of the globe, and data is lacking. And I also speculate, and I don't know if Amy and Janindra can jump in and add something, that if patients develop a perianal fistula, I speculate that the diagnostic delay would be shorter than from luminal disease sometimes, because it's the tip of the iceberg. They go for a colorectal surgeon to try to see what's going on. So that's a wonderful scientific question, Elsa, that we should really try to answer with groups like this.
Yeah, I agree, Paulo. If they have a fistula, I think that the diagnostic delay is probably much shorter just because it prompts, I think, faster evaluation in general. So that would be very interesting to look at the delay in a luminal presentation versus a fistula presentation, I think.
But don't you think even when people present like to a general surgeon with perianal disease, I don't think the first thing they think of is Crohn's, right? They're thinking just cryptoglandular disease. And that's such an important distinction that I think just awareness needs to be raised amongst general surgeons as well.
Yeah, and sometimes this is so hard to manage because usually we have those patients with those easy fistulas or even surgery for hemorrhoids and fissures, as I wrote in the chat. And these patients do not heal, and then the suspicion is higher for a diagnosis of Crohn's disease. So I think you're right. The general surgeon sometimes does not, have the recognition of a red flag, but colorectal surgeons mostly do have.
Just to add some data from that, so from the UK, there is some hospital episode statistics looking at people who present with an abscess, and there's a median time to delay for Crohn's in some of those of over 12 months. So I think it's still a problem from data we've got in the UK.
We
I'd
have
like
similar
to jump
data.
in. Sorry, Jeremy.
No, go ahead.
I wanted to go back to the earlier statement about the primary care and not recognizing perianal fistulas and abscesses. And I think we could do a better job and maybe perhaps discuss in this guidance of when to refer to a gastroenterologist. The foundation recently published undiagnosed referral guidances, and perianal fistula and abscesses are among the reasons to refer. So if we could do a better job working across our primary care space to get patients to a gastroenterologist, I think that can also perhaps, because this is a big issue, address some of the social determinants of health that Jeremy mentioned as being one of the reasons fistula develop.
I can't remember how much time we have for this discussion. I know it's 10:14. If we're going over, just let me know.
Nope. 15 more minutes. We're going to 10:30.
Oh, perfect. Yep. Okay, thank you. So maybe just a question for the group. Towards my presentation, what does the group? It'd be nice to kind of get some consensus on So I think we probably all agree that all patients with Crohn's disease at the time of diagnosis require an exam of the perianal area. You know, we're going to do that when we scope our patients. Does the group feel that there are any patient subgroups or all patients that should undergo an MRI of the pelvis? Are we there yet with that? The few studies that are out there on subclinical perianal Crohn's disease? Jeremy?
I think that study that you and I both had pictures from the slides, the Kim was the first author, really drove home the point that there's a lot more subclinical fistulas than we realize. They found it was almost 20% of patients. So I think that really does raise the importance of doing pelvic imaging for all of our patients, even the ones who don't have perianal symptoms.
How does, I mean, that's a lot of MRI imaging. I know at our center in Canada, it can take months and months. And if we start to do this, we might be looking at 6 months to a year to get MRI imaging for asymptomatic patients, maybe even longer. How does everyone else feel? Or do we need to look at subgroups?
I think that Jeremy made an excellent job in reviewing risk factors. I'm not sure, Jeremy, if we should really screen all patients, or we should concentrate in those risk groups that you very well delineated.
I think one question too is, what are we going to do with the information found on MRI? So is it going to really change the treatment of the patient? So if a patient has a known diagnosis of Crohn's and they're on medical therapy and they're doing well from a medical therapy standpoint, and you're not thinking of transitioning them to a different medical therapy, then what really is the utility in getting an MRI? If we can examine them and there's not an undrained abscess and they're relatively asymptomatic, great to get the MRI, but then what are we going to do with that information? So I think for me, it becomes is there going to be a change in management as a result of the imaging?
I think, Amy, that if I have a patient with a fistula that is there, shown by MRI, but still not having symptoms, but the fistula is there, I would be much more prone really to start this patient on an anti-TNF and not just try a course of corticosteroids, and if he gets into remission, doing nothing else. So I think that it may have practical implications. Of course, we don't have hard data supporting that attitude. I admit that, but I think that it may have implications.
Yes, so exactly as you were saying, if it's a patient, if you're thinking about starting them on therapy, yes. But I'm saying is if you have a patient that is already optimized on medical therapy and you're getting ongoing imaging that wouldn't necessarily change your management medically, then I kind of question the utility of MRI. So I think it could be really useful if you're at a decision point of how are you going to manage the patient. But if you're thinking of ordering it, but it wouldn't necessarily change the subsequent steps in management, then to me, that becomes the time where I say, I'm not really sure how useful this MRI would be.
Yeah, so I think in response to both of those points, I agree that if you're starting therapy, this could tip you to selecting one treatment over the other, and preferentially an anti-TNF. Whereas if I had a patient who was on vedolizumab and was in endoscopic remission, then so no, I wouldn't be switching therapy. So it's, I think, in that the undifferentiated, or not undifferentiated, but prior to initiating therapy. And I think one of the challenges, again, and at least in Canada, is time to MRI exam. You're often not going to wait for the results to start therapy in a patient with subclinical perianal fistulas. Jeremy, you have your hand.
Stacy had her hand up first, but
I just wanted to say, I mean, I'm a parent of my son was diagnosed with Crohn's disease when he was 2 and he's now 23. So he hasn't had perianal fistulas. So also just thinking about the pediatric perspective, like, would there be, like it's hard to keep doing all these extra tests, and you have to consider all these factors of like, how is it affecting them? And they've already, would there be something different that you'd have to do to look for the perianal fistula? And also because he has stricturing Crohn's, like, is that an increased risk? So I think like, I'm just thinking about the pediatric population and how the impact of doing all these tests on them and trying to figure out if there is an increased risk and maybe doing it then. But, again, just considering all the things that they're already going through. So.
Thank you, Jeremy. Go ahead.
Yeah, actually, my comment and question relates to that is, what does everybody do as far as small bowel imaging at diagnosis? I mean, we do an MR enterography to understand the extent of disease. And once we're doing the MR, it's easy to just add on a perianal protocol.
Our site will not do both of them at the same time. They require the patient to come back for 2 separate ones. I was going to ask the group if they're able to get perianal images, because if they could, that'd be great, but we can't.
Yeah,
we can't either. It's 2 separate tests and 2 separate charges, et cetera. So it's we can get a limited view on MRE, but an actual MRI pelvis fistula protocol is a totally separate exam with separate charge, et cetera.
And sometimes we're even a separate day, depending on which scanner. I was just going to say, I do EUS, and we will do it for anyone that has any perianal complaints, which is helpful. But I guess it kind of depends on where your threshold is for starting an advanced therapy. I think majority of our patients are going to be on an advanced therapy unless there's some compelling reason not to. So it hasn't really changed management as much, although it's helpful to know if they need to be monitored a little bit more closely.
So if I can add something, yeah, thanks for that. I found the button here. It's reactions, the happy circle there. So I'm going to lower my hand. I'm learning still. But anyway, just to give a non-US perspective, I know there are people from Europe and whatever, but from the Latin American perspective, it's not easy to access those tests in patients without clear findings of perianal disease. So we struggle sometimes to have an MRI. And the same was happening when I was in Calgary. There was a 6-month waiting list for an MRI of the pelvis sometimes. So I do believe that, of course, the results of this meeting today from this outstanding group of experts, it's not going to stay just in the US. I mean, it will probably cross borders and be as, let's say, as a guidance from people from all the areas. So I do believe that it varies a lot depending on the region of the globe. We also struggle with different codings, even in private patients here in our referral unit. So I do think that we need to take a clinical suspicious, of course, in a very good level, and not trying to maybe doing MRIs as was stated before for all patients. So we really need to be very precise on that, I think.
Thank you, Jordi.
Yes, thanks. Just to mention that, try to connect with different points raised before. So in this Korean study that is very interesting and shocking a bit, different points. First of all, only 30% of patients progress to an open perianal fistula. That seems relatively low. There is no prospective data with intention to screen patients with perianal disease. Usually these findings are incidental findings on the bottom slices of the MRE. And so when we identify this on clinical practice, usually is in the context of a patient being diagnosed of Crohn's or with a flare. So I have some concerns whether or not these findings will modify the treatment of this patient, unless they are clearly symptomatic or so. But this, in my opinion, is not very representative. And the other point is that trying to implement specific tests for perianal fistula as a screening tool outside the US could be, as Paulo pointed out, could be very difficult. So probably we need to something very short, relatively inexpensive, like and well tolerated by patients, like transperineal ultrasound, or just selecting patients with a clinical profile of high risk or symptomatic symptoms in the perianal area. Something like this could be more feasible for screening patients at risk of perianal disease. So this is the perspective as a radiologist in that point. And thanks.
So can I just try to summarize? So maybe we have somewhat consensus on this point. So I'm hearing, we've heard from the patient perspective that sometimes added tests may not always be best for patients. We've heard that the incidence of subclinical perianal fistulas is still relatively quite low. We're not sure if it's always going to impact our management. There's access issues. So I think, would it be fair to say that that at this point we don't routinely recommend this supplemental imaging, but to have a low threshold for patients who do become symptomatic, and maybe in the future to consider high-risk patients, maybe, and of course, further studies would help to clarify it?
That was a great summary, Jeff. That was good.
Okay. Jeremy, I think you had a point.
Yeah, no, I think that was a great summary, but I think if we could add a caveat, if in the right setting somebody is already doing an MR enterography and they're able to include perianal imaging, I think if they're at an institution where it's not a burden to add that on, I think that extra imaging could be useful.
And maybe if, as well as access to ultrasound becomes more widely available, then in that scenario, we can also add it in there.
Sorry, that is something that I'm talking to my physician about right now is, do we want to go the intestinal ultrasound route? I am at Mount Sinai, so I know they've been helping to pioneer some of that. That's why I posed the IUS question, because that might be more accessible in other countries and might be cheaper. I will say, just in agreement with Stacy, taking time off from work, school, to have all these CTONs placed, to have MRs done, or if you go to Mayo Clinic, Cleveland Clinic, which have like a beautiful system set up where, once you make an appointment with a physician, they'll sort of order different testing and you'll get it done over the course of a couple of days, 2-3 days. I think that works beautifully because we're already fasting to scope and to, have an MR or CT or whatever. I just think that getting things done in those sort of clusters works better for us as patients too, because we don't have to fast as often or go through all of that testing over several months. There's a lot of trauma associated with testing too. So just trying to figure out ways to streamline this for patients too.
Okay, excellent. And we only have a couple minutes. Can we just shift focus for a second? The patients with undifferentiated perianal fistulas, do all patients require an evaluation for luminal Crohn's disease, the full workup, ileocolonoscopy, small bowel imaging, capsule endoscopy? Should we be selectively doing this? I'd like to hear from some of our surgeons as they see these.
Yeah, maybe I can start. Maybe I get started, and we hear from Amy and Indra probably. So the aphorism, know it when you see it, when you gain experience, is quite interesting here, because if you see a simple fistula in a young patient with a typical history of a simple abscess for spontaneous drainage or even surgical drainage, and you see there's no tags, there's no fissures in association and simple tracts, usually those patients do not need a full examination, in my opinion. However, those patients with 2 or 3 sites, different sites for drainage, complex fistula, those are the patients that probably deserve special attention, mostly those with elevated fecal calprotectin. And I'm not talking about elevations of 300, 400, what we see commonly in fistulas, but those with 2,000, 1,000, and 500. So very elevated calprotectins maybe can help to screen those patients. Not sure if Amy agrees with that.
Yeah, I completely agree. I think from the surgical standpoint, it also really depends on when the patient comes to us, who else they've been seen by, because it's really variable for us in terms of when they present to us, if they've already had some evaluation, if they haven't had some evaluation. But I agree with Paulo about using a cutoff of a fecal calprotectin. I think it's a great test to use, given it's non-invasive and certainly potentially less resources in some of the other things. But I do think if there's a suspicion, I think doing cross-sectional imaging and endoscopy and sort of staging the patient is very beneficial. But I think in doing that, you know, as a surgeon, I'm really first calling the gastroenterologist to do that in conjunction with them. I'm not doing that in isolation. So I think that from a surgical standpoint, it's reaching out to the gastroenterologist and making that decision together so that things aren't repeated. Just from the hat that I wear. I think it's different from the GI standpoint. So I think it'd be interesting to also hear from the GI group.
Yeah, I think it's an opportunity for education. You know, I think our surgeons at our site are very good at referring to us when something looks funny with that fistula. It's not healing right. There's several branches. It's the third operation. You know, I think it might be a good education for the general surgeons who may not come across a lot of these of when should they be kind of referring to their GI colleagues for a better workup, you know, when you see some of these unusual things. So I wonder if that's an opportunity to educate out in the community.
Any other thoughts before we close? So I guess what I'm hearing is that not the full workup, not necessary for everyone. Fecal calprotectin is important. If there's anything funny, more complex disease, and elevated fecal calprotectin, anything on the clinical history, then these are the patients where we'd have a lower threshold for a more complete evaluation.
Yes, I agree with that. I'd also be curious to understand how we get the word out about ordering the fecal calprotectin, because I think for us, you know, in an IBD community, that becomes a very normal part of the conversation. But I would say for the general surgeon, I don't know if Paulo and Janinder want to comment on this, but for the general surgeon or perhaps general practitioner, I'm not sure that fecal calprotectin is really part of the vernacular as much. So I think it would be interesting to think about how we could propose educating around that as that being a good initial step for a non-invasive test.
And I guess along those lines, if this eventually is published in more of a GI journal, it may not have widespread distribution to surgeons, especially those who don't primarily treat IBD.
Yeah, that's perfectly. The observation is key, and I would also add that the very good clinical examination by a colorectal surgeon also can amplify in referring those patients for further investigation.
Totally agree. I think when we see patients, they're coming from a lot of these rural communities that, like you say, don't see Crohn's disease that often. And sometimes they're sitting there trying to treat these and with antibiotics or doing this. And it takes a while before they eventually something presents and then they send them to, you know, the experienced IBD centers or whatever. But I think our rural communities where they're seeing patients out there, we have to get out there to educate them. That's where I think the key starts.
Right. A lot of damage can be done before the.
Yeah. Absolutely.
So maybe Laura, you have the last thoughts before we move on to our next session.
I'm just going to close it out. As part of this education, we have to help surgeons and patients and other caregivers know when to use fecal cal, but also how to get coverage for fecal cal and how to appeal when those are denied by insurers. Because again, we don't want to create a situation where we're asking patients to get tested and then they're having to fight their insurance companies in order to get the necessary testing and treatment.
Definitely. I will say it's a lot easier though now. It used to be very difficult, but it's definitely a lot easier to get that test.
It is, but as you start to use it more, they'll put up more barriers.
That's probably right.
Okay, so thanks everyone for your input into this session. I think we can probably move on.
We'll start session 2 about CPF diagnosis. At the end of the group discussion in this session, we'll have a longer break of about 20 minutes. We'll start with Dr. Kotze, who is our session chair. He's assistant professor of surgery and the head of the colorectal surgery unit at Cajuru University Hospital of the Catholic University in Brazil. Dr. Kotze is an experienced IBD surgeon and author of 2 books. Various articles and book chapters focus on Crohn's disease and ulcerative colitis. He has a special interest in the fields of biological therapy and surgery and IBD, actively participates on the board of directors for the Brazilian Study Group for IBD, and is currently co-editor of the journal Coloproctology. Dr. Kotze, when you are ready, please begin your presentation.
Thanks, Zoe. I hope everybody's seeing my screen. And let's update. We have now a third book with Janindra Varasavitarni, who's here. Is just a book focused in complex fistulas in Crohn's disease. Maybe we should give them, Janindra, the PDF of our most recent book. So thank you for the opportunity to be here with you today. It's an honor to be actually participating, representing Latin America in this meeting. So my job would be to try to focus on practical points on identifying perianal fistulas in Crohn's disease. Previous lectures were amazing, so much data out there. So I'm going to try to give a more practical flavor on this, as there's lack of data on pure things like physical examination and anamnesis of the patients. So let's start with some guidelines. So if we squeeze a little bit the guidelines that we have out there, let's start with the ECHO one. We will see that there are few statements focusing exclusively on identification of perianal fistulas in Crohn's disease. So, of course, unexplained perianal abscesses or complex fistulae should be investigated for Crohn's disease. We already discussed that. And of course, their assessment by clinical evaluation in combination with endoscopic examination of the rectum and MRI, as we were stating. They also focus a little bit on ultrasound in the absence of stenosis, and transperineal ultrasonography as a good point to identify those fistulas as well. We are very clear, according to the AGA technical review that was published years ago, that MRI is the most accurate imaging modality for this diagnosis. And of course, it's recommended in the first-line tests. We can discuss later on stuff about transrectal ultrasonography and the combination of these methods. But as a surgeon, I would defend our group and state that the examination and anesthesia plays a significant role on these patients. And I'm going to try to give tips and tricks on how to do that. And of course, the endoscopic evaluation of the rectum, as previously stated, we also can monitor patients on that. There was one consensus that was specifically focused on perianal fistulas in Crohn's disease, the Toronto consensus. It was published 5 years ago in the Canadian Journal of the Canadian Association of Gastroenterology. And there are simply two statements on diagnosis on fistulas there. So statement one stating that patients with established Crohn's disease and signs and symptoms on the perianal area, they recommend imaging and not specification, but EUS or MRI based on availability and local expertise. And in patients with Crohn's disease and evidence of complicated fistulizing disease, we suggest surgical consultation. And I think this statement number two plays a significant role in what we're discussing here today. So if we as IBD specialists, it depends if, it doesn't matter if you're a gastroenterologist or if you're a colorectal surgeon or general surgeon, we need to understand that clinical symptoms and clinical examination is a key in these patients. And again, usually what we have is like a GI calling us and saying, can you just pass by and give a quick look to my patient? It doesn't work like this. So we need time, we need to understand what's going on. We need time to examine these patients properly. So of course, listening to the patients is key. And symptoms can vary, as we heard from Tina and from previous speakers, what symptoms call our attention for perianal fistulas in Crohn's disease. It goes from a simple opening on the skin around the anus, signs of inflammation, secretion of pus, blood or stool from the tunnel opening, pain, discomfort, fever, and chronic infection sometimes can lead to us to call the attention from the doctors in order to try to identify those fistulas. But the physical and proctological examination is key here. And I think for doing so, we need to understand that we need facilities for it. We need adequate lighting for that. We sometimes need proctoscopes, endoscopes. Some people do have ultrasonography tests in the office, in the outpatient office. And I think this is also depending on the region you work, on the type of system that you're involved to in public versus private healthcare systems. So again, we need to see things very clearly, and you can, depending on the patient's health status, you can, position the patient clearly in order to try to examine this region better. Usually, most of us use the Sims position when you have a patient lying on the left side with flexed legs. And with this position, we can usually try to identify those fistulas in an easier way. And in terms of the anatomy of the perianal area, I'm very curious to hear what Jordi has to say. But for radiologists, at least, the anus seems like a clock. Usually, they describe tracts and openings, and depending on the region of the anus in associations with the clock positions of the numbers. But really, for surgeons like us, we try to usually nominate and report this in our descriptions as anterior left, anterior right, posterior left. So let's say that, well, there's an external opening in the posterior left quadrant, 4 centimeters away from the anal verge. So this works very well for us in order to try to precisely determine where those fistulas are. So I think the anatomy and the nomenclature that is used, the semantics, are very important here. And not only looking, but to palpate is also important. Where's the external opening? Is it single? Is it multiple? Can we identify or have a clue of where the tract goes through, where it leads to internal opening as a guitar string that we usually palpate that? Where's the internal opening? Sometimes it's difficult to find an internal opening in a clinical examination. Usually it's at the level of the dentate line, but in Crohn's disease, it can lie above the dentate line for some centimeters. So very important to have an experienced examiner here. And of course, there are those patients with associated stenosis, they have abscesses, they have pain. And for these specific patients, we need to understand the time to stop. So if we cannot palpate it properly, we need to schedule an EUA, an examination under anesthesia, in order to try to better locate those fistulas and map those fistulas for us to better understand what's going on and of course, to direct towards treatment. Because manifestations of perianal disease can vary a lot, we can have here one fistula, chronic one with some perineal ulcers, as you can see, another case with inflamed skin tags, superficial fistulas, some ulcers. Here, this specific patient with perianal fistulas and hidradenitis suppurativa in the groin. Here we see patients with a lot of dermatitis, several tracts around the circumference of the anus. Patients with a lot of ulcerations in association with fistulas, and those with stenosis and undrained fistula tracts. So manifestations can vary a lot. And it's our job to try to identify that as much as we can in a clinical scenario, I mean, in the outpatient basis. If we can examine them. If not, we need to schedule an AUA. Because we must not forget that there is a disease course specifically for perianal fistulas. Usually, as was previously alluded to, we start with some ulcers, and the evolution towards infection and tracts and fistulas occur over the years in disease course. So, I mean, if we can do an effective medical and surgical treatment, we can prevent fistulas to occur. And that's why I believe that patients with lesions like this, it's not a fistula yet, but it will be a fistula in weeks or months from now. Those large ulcers with inflamed skin tags, those are the patients that we need to examine properly. And these patients, usually they do need an examination under anesthesia, as we need to try to understand they have a lot of pain as well. So this is the pre-fistulizing state that we could have. And of course, we need MRI. I will not go into Jordi's talk, but I just say that we have to focus in MRI as the best method. Usually, we have the contrast enhancement in fistula tracts, where those fluid collections can be easily identifiable. And one main message here would be to sit down with the radiologist in an MDT way and try to understand properly what's going on. The group from Janindra Varusavitani and Ailsa from St. Mark's, they developed a lot of work in the 3D images, reconstructions of the MRI of the pelvis, and tried to identify the fistula tracts. And here's just one example of that. Well, Kapil Sanan published this paper years ago, but I think a video deserves better. This is a virtual fistulography, and these reconstructions really can impact in the future the clear mapping and identification of these fistulas. And mostly, we can also try to do 3D printing on that. And here you can see the fistula tract in green, you can see the rectum in red, and this is probably the best way to try to show to surgeons where the fistula tracts in order to try to drain them and in order to try to use the proper surgical techniques once we can do that. Brief words about endoanal ultrasound. Really, can we do that? So our experience with endoanal ultrasound or intrarectal ultrasound is not good, because mostly these patients have a reduced caliber of the anorectal ring. These patients usually have pain, stenosis, and this examination is really painful for that. So maybe if you use it under anesthesia, it can help. But it's easier for us to go for an MRI, and I believe in our practice that MRI is probably better than ultrasound. It's not operator dependent. The images are there. You can discuss later with the radiologist, but we can discuss that, of course, during our panel. What about the examination under anesthesia? The examination under anesthesia is key for us. Here we can, of course, understand better the tracts. Here we see we can probe the tracts, and easily we can identify. This is a patient with Crohn's disease with one single tract, as we can see, posterior right quadrant, as we see here, and internal openings in the midline. And again, we then can also take advantage on this diagnostic part and try to drain this and place some symptoms in order to try to optimize patients for the treatment in the future. So the examination and anesthesia has a diagnostic advantage, but also a therapeutic advantage, as we see. Here's another example in a chronic patient. This is a pediatric patient with years of perianal unrecognized and untreated disease. You can see that the tracts are all epithelialized, and there's not much we could do on patients like this. So this is what we want to avoid in the future. We want to understand that this could be prevented with early diagnosis, early effective treatment, and this is what we want to avoid in identification of fistulas, as we see. So in summary, we have to listen to our patients. We have to examine them very well. And then once we have the high suspicions of complex fistula in Crohn's disease, we can direct them towards imaging tests. It's quite a consensus that MRI scans with contrast enhancement, these are the best techniques that can be used to adequately map the perianal area. And once this perianal area is mapped with an MRI or endoanal ultrasound, we can discuss. You can refer the patients for an examination under anesthesia. Usually, MRIs can identify up to 20% of hidden tracts or hidden fluid collections or abscesses. So myself as a surgeon, I prefer to go for an AUA after the MRI so we can map the disease first and try to tackle it precisely with our procedure. So be suspicious, ask your patients, listen to them, do an adequate anorectal exam in outpatient clinics, palpate. It's very important, and this can be done by GIs and also surgeons. We need to be very precise in the description of number of tracts, openings, precise locations. This is key in order to try to have a basis for future management strategies. MRI of the pelvis is the best diagnostic method, and the EUA with experienced colorectal surgeon is also important in order to identify precise identification of these fistulas. I finish here, and then we can go on with the next slide too.
Excellent. Thank you. Dr. Hart. Dr. Hart is a consultant gastroenterologist at St. Mark's Hospital and Dean of St. Mark's Hospital Academic Institute in London. She's currently on the governing board of the European Crohn's and Colitis Organization, ECHO, as scientific officer, and was past treasurer and member of the clinical committee of ECHO. She is on the IBD Clinical Research Group Committee for the British Society of Gastroenterology and past chair of the Gut Microbiota for Health Group of the BSG. Dr. Hart, when you're ready, please begin.
Thanks very much, Joy, and thanks very much. It's an absolute pleasure being part of this group today. So many thanks for the invitation to be here. Can everyone see the screen? Fantastic. So 10 minutes to think about perianal anatomy and classification. First disclosure is that I'm going to leave it with Janindra, Amy, and Paolo to think about anatomy because I'm a gastroenterologist, not a surgeon. But what I'd like to think about in this 10 minutes is the key question is really why? Why classify fistulizing perianal Crohn's disease? I'll just take one moment to think about the P in the Montreal classification of Crohn's and how we're maybe thinking beyond that now. Think about some of the other classifications we've got of perianal Crohn's disease. Share with you a new classification we published last year, which I'm sure many are familiar with, but I'll just go through that and think about how in the future we can really improve on how we do classify this condition. So why classify? Well, if you look at why you classify anything, it's to construct clusters about which we can make inductive generalizations. And I think, you know, it's to have a consistent language. And that's a language actually, Tina, with patients, as well as with surgeons, with gastroenterologists, is to make sure we have a consistent language really across the board. It's to help with research so we can understand more about the biology of the disease, because that's going to drive our newer therapies. Is to help facilitate better clinical trials, because at the moment, many of the trials have got incredibly heterogeneous groups of patients going into them. So how can we actually classify to have a more homogeneous group going in the PICO when we ask the PICO questions? And of course, ultimately, it's to improve treatment for patients. So just as a reminder, the P in the Montreal classification, it was 2005. So it's nearly 20 years ago that the Montreal classification came about. So I think it's high time this was redone. And as many of you will know, there is a move to do a complete reclassification of inflammatory bowel disease that is underway at the moment through the IOIBD. And some of us on this call have been tasked to rethink a bit about how we might rethink the P in this. But just to go back to 2005, when the Montreal was done, it was Mark Silverberg who was the first author of this. The perianal disease modifier was in the behavior part, and it was added to each of those groups. So the suggestion was to include perianal fistulas and abscesses as modifiers in the disease behavior variable by adding the P to B1, B2, or B3. I think what it's shown us, though, is we've gone on and do pieces of work, and what I'm showing you here is just a very large, it was an international genetics consortium piece of work, trying to look at, say, genetic markers of some of the subphenotypes. And it very much highlighted this work, how inadequate something like the P modifier is. Because actually, even in a classification system, having a P added in, when you don't actually say that a P is not there, it's either P plus or P minus, so even that wasn't done. So it makes it very, very difficult to do the basic science that we are doing. And I think this subphenotype study that was done some years ago, which didn't show any major genetic association of perianal disease, very much demonstrated that, and the need to actually have a more consistent language, if you like. But let's just think for a moment about the current classifications that we've got of visualizing perianal Crohn's. So broadly speaking, they're divided into those classified based on morphology, so the anatomy, based on the fissular activity and response to treatment, and some based on both. And you can let your eyes scroll down through the ones based on morphology. You'll be familiar with many of these. And maybe just to draw your eye to, of course, the AGA one, which defines them as simple and complex based on the location, height, number of external openings, and the associated perineal tissues. Also, maybe another well-known one is the Parkes and the modified Parkes, again based purely on the anatomical features. If we then think about the description based on the activity of the fistula and the response to treatment, we have, of course, the data from present. That was from the Accent 2 study. Fistula Drainage Assessment Index, the PDAI, and I think we all know when we do work using these indices, the inadequacies of some of these ways that we look at fistulas, and some, of course, which look at both, and I'll leave it very much to Georgie to think about some of these, particularly the imaging side of things. This, of course, just to show you, is the Parkes classification based purely on the anatomical side of things. So what a group of us decided to do, and this is actually, it was just predating the pandemic. It was the ECHO in February 2020, just before the pandemic kicked off. We met at ECHO, and you'll recognize many of the faces there. I think you can see Amy there. You can probably see who else. We've got Janindra's in there hiding behind, I think it is Christiana. So many of the people that European meeting. And we set up this initiative, which is now called the Top Class Perianal Crohn's Consortium. It is a very inclusive consortium and always keen just to include people within it. And it stands for Treatment Optimization and Classification of Perianal Crohn's. Really aiming to think about this classification piece, defining treatment endpoints, and of course, trying to get better treatments for patients. And just in the next few minutes, I'll share with you what we published a year ago now in LGH, this more novel classification of perianal Crohn's disease. And what we particularly did with this was we involved patients as well as gastroenterologists, surgeons, and radiologists in how we did this bit of work. And broadly speaking, what you can see from this is that there are 4 major classes. So class 1, 2, 4. The other thing you can see immediately is that patients can move between the different classes. So it's a flow in different directions, either getting worse or getting better with treatments. And the other overarching thing that you can see, particularly if you draw your eye to the 2C1s and the 2C2s, is something to do with the velocity of the development of disease, which I think is another feature that we often overlook in how we classify IBD. We know that some patients' disease seems to go at quite a pace, and other people it can be a much slower pace. And I think it encapsulates that velocity of advancement of disease as well. But just to walk you through the different classes. So class 1, this is the group that, that Jeremy, you touched on earlier. It's this group with minimal disease. It's not quite the subclinical disease, but nonetheless, it encompasses this group of patients with minimal symptoms and anorectal disease burden, requiring actually, I think, minimal intervention over time. We all recognize that is a group that we see in our clinics. I think what we don't understand, as we've already touched on a bit, is we don't know exactly the natural history of that, what we need to do about it, and so on. So it's a class that needs a bit more thinking. Then the vast majority of the patients, certainly that I see in the clinic, are the class 2 patients. It's this chronic symptomatic fistulae, and broadly speaking, this group are divided into 3 groups, 2A, 2B, and 2C. So these are the patients who will align with one of those 3 groups, depending on these major factors that you can see in the red ring there. So it's very importantly, it's the patient goal. And this was something patients were very keen that we inserted in this classification, because how you manage patients with perianal Crohn's is very dependent on what a patient wants. So we wanted to insert goals in this group of patients. Of course, it also depends on the symptoms and the impact of those symptoms on quality of life, the fistula anatomy, and the anorectal disease burden. And then within that, you've got the 2A group. Now, these are the patients whose fistulas are suitable for a repair with combined medical or surgical therapy, and the patient's goal is fistula closure. And that's the important part of this group. The 2B group of patients are those who've got, again, the chronic symptoms, but they are unsuitable for surgical repair. And again, Janindra and Amy Paola can talk about this definition of suitability. It's to do with the anatomy, the straightness of the tract, the number of internal openings, and the quality of the rectum. And importantly, the patient goal is symptom control, because we know that some patients actually don't mind a ceton. And actually, they just want to have their symptoms improved. And actually, they would rather have that than having the ceton removed and then have the recurrent problems of going back and forth for further interventions, if that's not their ultimate goal. And then you can see how patients can move between 2A and 2B if they worsen, or indeed how a 2B patient can downgrade to a 2A and then potentially be suitable for repair that Janindra or Paolo or Amy could do. The 2C patients, again, what this group differentiates is whether the disease is very early and rapidly progressive. And I think, again, we will recognize that group of patients who fairly quickly after they develop this perianal fistulizing disease need to come to defunctioning to get disease control. And contrasting that with this group that we described, the gradually debilitating, which are flowing more from the 2B group of patients, where actually that group of patients, their goal is actually to have a stoma to actually help with their symptom control. And then class 3 and 4, it makes the very clear point that even when patients have gone down this road, that isn't the end of the story for many patients. So class 3 is those patients with what we've described as an exhausted perineum or adverse features needing a proctectomy. And then the class 4 patients makes the point that even after a proctectomy, we see differences with regards to patients who've got symptoms where a repair is possible in the 4A group, and need symptom control in the 4B group. And again, you can see how some of these definitions and classes not just help with the management of the patients, but also potentially how we might think about trials in the different groups, because there are almost no trials in a lot of these groups, particularly say for the class 3 and 4 patients. So the final slide is, how to improve this classification. Well, it's being assessed and has been assessed by some groups already in retrospective series. Of course, to try and prospectively look at it is another way to do this. And very importantly, I think any classification, it's a starter. It is a starter for 10 to put something like this in front of us. And it will need amendments, and it's an iterative process. And I think unlike the Montreal classification, which has taken nearly 20 years before anyone is doing something about it, we'd be very keen that there are more iterations on this classification. And indeed, we're already thinking about class 0, maybe to represent the healed fistula, or a -1 to represent an abscess, things that already people have said need amending on what we've put in front of people. Do patients identify with the classification? Well, interestingly, and I'd be very keen to hear your views on this, Tina, when we put this in front of patients, they can identify what group they are in. And we developed this, it was co-developed with patients. And of course, using this sort of classification, it's moving us towards potentially a biological classification, how we can look at some of the very nice biology that was shown earlier, and actually look in a slightly clearer way in these different groups. We'll hear from Geordie next about radiology and how a radiological classification can be helpful. And of course, ultimately, the goal is to improve patient care. Thanks very much.
Thank you. Our next speaker is Dr. Romola, who is a consultant in abdominal radiology in the abdominal imaging unit of the Department of Radiology at the Hospital Clinic in Barcelona, Spain. Dr. Romola has published widely on subjects related to the application of MRE and MRI in peer-reviewed journals such as Gut, Gastroenterology, Radiology, Inflammatory Bowel Diseases, Journal of Crohn and Colitis, and Alimentary Pharmacology and Therapeutics, among others. His research includes characterization of bowel fibrosis in patients with Crohn's disease and exploration of therapeutic targets based on cross-sectional imaging for luminal and perianal disease. He is currently a member of the European Society of Radiology, the European Society of Abdominal and Gastrointestinal Radiology, and European Crohn's and Colitis Organization, and is the current president of the Spanish Society of Abdominal Radiology. Dr. Romola, I'm running your slides and we'll share those shortly.
Sorry, I sent you a pre-recorded. I don't know if you are using to use my pre-recorded, or I have to share my screen.
I sent Joy the slides you sent me. We're all good.
It's up to you. I can do it in direct if you want.
We are all ready to go to share your slides pre-recorded.
Yes, sorry, I actually did start them. Just a second, I will restart.
Imaging techniques in the evaluation of perianal fistulas. These are my disclosures related to this topic. Specifically, in this lecture, I will make emphasis on the ideal characteristics that an imaging modality should have for characterizing a fistula in Crohn's disease, and to review the different imaging modalities currently available to assess fistula anatomy. It's well known that imaging modalities are superior to clinical examination when assessing perianal fistulizing disease. An ideal imaging modality for diagnosis of perianal fistula should be able to tackle its complexity. In other words, it should provide a virtual roadmap so that surgeons or clinicians may get useful information to optimize the best therapeutic approach. Other characteristics of the imaging techniques should be available, tolerable by patients, and reliable. A valid imaging modality should be able to connect the external draining openings seen at physical examination with the internal inflammatory lesions, including primary tracts, extensions, and eventually some collections. The minimum data set that an imaging modality should report for best characterizing fistulas include the number of primary tracts, the location and number of internal openings, the relationship between the fistula tract with anal sphincters, the presence of secondary tracts, and especially collection, because are of one of the main causes of fistula recurrence, should provide information regarding fistula activity, the location of cetones, especially relevant if fistula are not responding to surgical treatment, and also rectal inflammation. There are different imaging modalities available at this time, being magnetic resonance angiography, endoscopic ultrasound, and transperineal ultrasound, the accepted or recommended imaging modalities for fistula detection and characterization. Computed tomography and the classical fistulography are not recommended because they not provide anatomical information and expose patients to unnecessary irradiation. There is a classical prospective small study, including 32 patients with suspected perianal Crohn's disease, comparing the accuracy of endoscopic ultrasound examination under anesthesia and magnetic resonance for fistula detection and characterization, showing that all three modalities has a very high diagnostic accuracy. In addition, combining two modalities, the accuracy was 100%. This study is highly cited because of the impact of the results, but this study was published in the early 2000s, and since then there had been several technological improvements in the field of MR and in the field of ultrasound, so probably the accuracy of the technique should be higher than it's reported. Magnetic resonance imaging probably is the best characterized technique for fistula characterization. It's a multiparametric technique combining different pulse imaging sequences obtained by magnetic resonance and provide a very detailed anatomical information coupled with functional imaging, meaning that is able to characterize the tissue lesions, including fibrosis, lesion in the perianal disease, granulation tissue, fluid, etc. Also, MRI is able to provide multiplanar imaging that provides different views of the fistula in the different anatomical positions. It's not invasive technique. The examination is obtained by putting an anthenes over the pelvis of the patient, so there is no invasiveness, and therefore it's well tolerated by patients. MRI is able to provide a high spatial resolution and panoramic view that is particularly important in complex perianal fistulizing disease where secondary tracts may be located far from the anal canal. It's also reproducible, and therefore, because of its inherent characteristics, some authors consider magnetic resonance imaging as the gold standard for perianal fistulizing disease. It's very important to remark that in addition to identification of fistula tract, it's able to provide information regarding some other relevant lesions like secondary tracts that can travel far from the anal canal, or to the collections that can be located anywhere in the pelvis. Some collections may be located nearby to the anal canal, but they could be located far from the anal canal. So it's important to provide this relevant information for guiding drainage of these lesions. The main limitation of MRI is that it's not readily available in case of urgent need of guiding interventions. Endoscopic ultrasound is the main alternative to magnetic resonance imaging. It delineates the internal fistula openings together with the sphincter complex and the main fistula tract nearby the anal canal, such as it can be seen in this example. This information may be very useful before planning surgical intervention. It's also worth to mention that the technique is available in case of urgent need, but it's surrogated to local expertise. The main limitation of endoscopic ultrasound, in addition to the tolerability of the patient because it requires intubation of the anal canal, is that it has a restricted view beyond the sphincter. In this example, we have the internal sphincter here, the external sphincter here with the fistula, but beyond the external sphincter, the view is restricted. So it's the diagnostic capability of this technique to identify secondary tracts distant to anal canal or distant collections is limited. Also, it's an operator-dependent technique, requires expertise, and it's low reliable to distinguish active or septic tract from fibrotic tracts because all of them have hypoechoic appearance. This is especially relevant in case of recurrent fistulas. Finally, we have transperineal ultrasound that had been recently proposed as an alternative to endoanal ultrasound. Like endoanal ultrasound, it provides high resolution images of the anal canal and nearby fistulas. Also, like endoanal ultrasound, it's limited by depth, and one potential advantage compared to endoanal ultrasound is that because it not require intubation of the anal canal, one may think that it's a painless examination, but in a recent publication, up to 40% of patients manifest some degree of pain. Finally, it's worth to mention that transperineal ultrasound is less commonly used, so operational characteristics of the techniques deserves further attention. This table summarizes the performance of different imaging techniques in different scenarios. MRI is able to characterize both simple and complex fistulas and is an excellent technique for identification of extensions and collections, whereas in ultrasound techniques are very useful for simple fistulas, but because of its restrictive view may have more limitations for characterizing complex fistulas, distant collections, and distant extensions. In terms of availability, ultrasound techniques are readily available in case of local expertise, whereas MRI is widely available except in case of urgent needs of surgical interventions. In summary, imaging plays an important role in the multidisciplinary evaluation of Crohn's perianal fistulas. The choice of imaging techniques depend on local expertise, local availability, and the complexity of perianal fistulas. MRI is currently the preferred technique for assessing fistula anatomy and depicting the relationship between the fistula and pelvic floor structure, extensions, and collection. So, in summary, it's the preferred method unless urgent need of guiding interventions. Endoanal ultrasound and transperineal ultrasound may be an alternative to MRI. Thank you very much for your attention.
Excellent. So I think we can start our discussion, and we have half an hour to do so. And very pleased to try to guide you through some questions and some better understanding on these problems. So maybe I could start summarizing that probably the sequence of events here from the talks would be clinical evaluation, followed by imaging investigation, and then classification. I also would agree that it's better to classify those patients after an MRI, for example, or would we dare to classify patients before complementary imaging tests? What's your opinion on that?
No, completely agree, Paolo. To have the clinical, all of the assessment, EUA, clinical, MR scanning to help the true understanding. Yeah.
Yeah, I think this is probably the best way to do that. One of the things that we also, from the clinical perspective, I'm not sure if Amy and Janindra also agree with that, is that sometimes patients, they do have pain and they have like an abscess or so, and physicians insist on having an MRI scan, and it takes probably weeks to do so or even more. And I think one important issue is try to recognize that before and try to intervene before these imaging tests, as Jordi alluded to. So do not delay adequate drainage, for example, of a hidden abscess or so, by waiting for let's say an MRI or an imaging test. And this is something that happens often. I'm not sure if it's the same in your practice.
Can you hear me?
Yeah, we can.
Okay, great. So I just wanted to say that I think that point is really important, because if you've got someone who has an abscess particularly, or their pain is more, or anything like that, we shouldn't necessarily wait for the MRI. I think we're, at least under the colorectal sections, we're very good at working out what's happening, especially with those tracks under EUA. So I think we have to sort of do that, because what the MRI does is it gives you essentially an idea of what the anatomy of the fistula is like, and exactly as you showed, even with the 3D and so on. And that gives you a starting point where you can move forward, but it doesn't mean that you have to wait for that starting point if there's something that needs to be done urgently.
Can I ask a question then around that? If so, let's say you do take someone, you drain an abscess, and then you get imaging and you realize there may be a fistula that you didn't appreciate. Do you bring them back to do another EUA, or just wait and see what happens?
I think if there's something that's undrained. I don't know what Janindra and Paulo think about this, but if there's a fistula that's asymptomatic that we didn't see, at the time of EUA, then I don't think we're necessarily surgically intervening on that fistula unless the MRI came back with a supralevator or something that we didn't see that then is an undrained collection that needs better control.
Yeah, I agree.
It's a good point. What is not seen by physical examination or ultrasound, it's not seen. It's unknown. So I think it's worth doing a re-scan the patient after surgical intervention, just to make sure that everything it's in correct place and not avoiding further complications. Is something that it may happen. So it's, from me,
I think it depends on the patient at the time of the EUA about getting imaging afterward. I think if there's really no proctitis and very limited anal canal involvement, and it looks to be a simple tract that was, clearly identified, a clear internal opening, I don't think we necessarily need further imaging. I think if there's more complex disease, there's luminal involvement, there seems to be branching, chronicity, lack of healing. I think some of those factors would prompt more imaging, but I think it really depends on what's seen at EUA.
Yeah, I was thinking about the complex.
Sorry, Judy. Janindra, you wanted to say something, I believe?
I don't know. It's pretty much the same. And I think it's as Amy said, it's looking at those, especially anything supralevator or anything extending anteriorly over the sphincter. Sometimes you get patients who get pain up there. Those are the ones that we can sometimes miss on surgery, and they're the times we would go back. Otherwise, it's very much symptom dependent.
Yeah, and before Julian and Jeff ask their questions, maybe we could just have a consensus between the three of us as surgeons that this is a rare event. So most of us, we have experience on examination and anesthesia, and even if we drain an abscess on the left side and there's a fistula tract on the right side, we can identify it. However, those of supralevator abscesses, those hidden abscesses that sometimes can occur, they're usually out of the reach of our EUA sometimes, but this is a rare event. I would say that we cannot say that there is a routine to try to scan these patients after adequate drainage and EUA, and this would be in an individualized fashion, I would say. Julian, please.
Yeah, sorry to change a little bit gears here, but we can tackle this question now or later. But I would like really to ask Elsa about which would be the most adequate classification, in your opinion, for the development of clinical trials, because it will be some time until we have your new classification of the top class. All what we have now, it's the AGA classification, and even it's not considered only that the criteria of complex fistula, but nothing else than that when we select patients for treatment. And I have never seen an analysis of response by other fistula characteristics. So if we have to design now a trial, medical or surgical treatment or combination treatment in patients with perianal fistulizing disease, what would you advise in terms of classification of fistula?
No, it's a really, really good question, Julian. And, I suppose from Admire 2, that's been the closest it's got to being quite discreet, because that's the 2A patients. That's the patients who've got a normal rectum and no stenosis and, fairly simple tracts to deal with. So that's been the closest so far, that the P and the PICO is probably the 2A patients. The problem with things like accent 2 is it's the whole class 2, it's everything. So some of those patients could have had much, much more complex disease, almost needing defunctioning, and they were all thrown into the same sort of pot, which I think makes it very, very difficult to really unpick. But, there might be a time that we could envisage where you might want to do a trial in the 2B patients who've got much more complex disease, where the outcome measure is a quality of life measure, because the goal of that patient might not be to pull the seat on, because they might just want to feel better and get on with their lives in a quality of life way, and then use the outcome measures like the Crohn's anal fistula quality of life measure that quite a few of us on this call have been part of developing as the primary outcome. But again, we're quite away from that because EMA and FDA haven't completely bought into some of these quality of life outcome measures. But nonetheless, it still feels that we're still throwing everything, a very heterogeneous group in, and expecting sense to come out. And we need to start sort of grouping things a bit more differently, and maybe thinking about 2A patients. In the UK at the moment, there's a surgical trial that might be starting looking at the 2A patients with a surgical intervention purely to look at that group of patients, with the outcome being healing, because that's the right outcome for those patients, and pulling the seat on. But I've been on so many pharmaceutical calls where so much of the chat is about pulling the seat on, and we might be missing the point there, because it might be in some of the 2B patients, that isn't the goal. The goal is to make the patient feel better and maybe avoid stoma, because they're sort of further down the whole pathway. But again, it's just as a starter, really, this whole construct to think maybe in a slightly different way about how we do trials and how we measure outcomes, literally thinking about the PICO in the different groups.
Jeff, question from you?
Well, more just a comment. Back to the discussion about MRI even after surgical intervention. I think maybe some emerging evidence that MRI has important prognostic value even before starting medical therapy. So I certainly like to have the MRI to help in the discussion with patients in terms of the need to start therapy, and then even to give them some idea of prognostic value and what their chances of responding to anti-TNF therapy is.
Yeah, that's an excellent point, because of course we won't start a treatment if patients don't have a previous MRI. It could be even before this drainage or even after, but your point is very well taken, I believe. Michelle did a very good comment here, saying that she likes the 4 classifications, and we need to understand that the patients also need to understand. Michelle, you want to make a comment on that? If so.
Yeah, I mean, I feel like there's not a lot of, education for these patients. I mean, we sit down and we talk to them, we do things, on them. We do the CTON or we do various things, but I think it would be really nice to actually talk about even a diagnosis, when we talk about the possibility of fistulas, and just having sort of, to see the progression and what could happen if patients do develop perianal symptoms or whatever, to recognize that and to say it to a patient. Sometimes patients don't say anything about their perianal area. I mean, they don't want to talk about it. So sometimes patients will present and they've never said anything to their doctor. And I always even talk to like house staff, residents, medical students. You always look at that perianal area because the patients don't know what normal is. And you have cultures, and sometimes they don't even want to talk about things down there. So I think if we could frame this in a way that this could also be a very nice educational tool of, the presentation of it and how it can progress, so that they understand from the get-go, how important identifying these and treating them is so that it doesn't progress. So I was just thinking, it'd be a nice educational tool to format like this in those with minimal disease, because we do see those, and we're not going to make a hole where there isn't a hole. So is sometimes just an antibiotic in the beginning for something very simple till we can actually evaluate it, further. I'm just thinking along that lines for education with patients to get them more involved in this process and decision-making too.
So encouraging doctors to ask about it routinely and not ignoring it. Yeah.
And look,
you
have to visually look on the outside.
Yeah.
Ask, listen, and palpate. Don't forget that. Ask, listen, and palpate. I told you that. So Tina, from your perspective, I read your excellent point on cultural things in the chat. So you wanted to make a question or a comment?
Yes, actually, a little bit unrelated to the cultural aspects and more of the general aspects based on what Michelle was saying. Something that I haven't seen enough of, and I wanted to propose as part of this consensus conference, and of course, we can discuss this with the AGA, is some patient resources that can be created around CPF, or just fistulae in general. I'm going to be very honest with you. My first diagnosis with an RV fistula was 2011, late 2011. I didn't see anyone talking about it. Released a blog post on this in early 2019. It exploded. To date, it is my #1 read blog post, and like up in like the 20,000 views or something like that. And the reason why I'm emphasizing this is so many patients have come to me since that blog post just talking about CPF, saying that they don't know how to bring this up to their physicians. Just to say what, to corroborate what Michelle is saying as well, they don't know how to bring this up. My surgeon would often check my bottom to see if there were fissures and skin tags, because I would talk about having a lot of pain with fissures. So that was diagnosed more easily, but trying to tell your surgeon or your GI there's stool or blood or mucus passing through into my vagina or out onto my skin, and that I'm wearing diapers and stuff, it's a very, very hard thing to talk about. It's hard enough to seek a diagnosis of IBD, but then to say that this is happening, it's just so violating, and it feels so shameful and disgusting on so many levels, that I agree with Michelle. It's not something we readily bring up to our doctors. I know I struggled with it a lot until it became an emergency and I needed to have a CTON placed that first time that it happened. I want to see more resources in the space. Perhaps it's something that we can talk about developing, or that patients can be involved in developing, not just myself, but others as well. Because what I'm seeing is that patients don't have enough knowledge on what's going on, or how this should be diagnosed, or even to bring this up. I've had caregivers even come to me over the last few years saying, I never heard of this. And, I asked my daughter's physician or my son's physician about this because, my child was starting to see some sort of symptoms like you were describing. We need pamphlets. We need more on this to be distributed, across different methods, through doctors' offices, through social media, through the Crohn's and Colitis Foundation and different grassroots organizations, so that patients can really bring this up to their doctors.
Excellent. Jeff, you want to raise a point?
If anyone wants to comment on that, please go ahead. I was going to kind of shift focus.
Well, I was just going to add to that I also have patients reach out to me about that, and they do feel very isolated. They also want to connect with other patients who've gone through that. And I think like helping provide a resource or a way to do that, because like if you have I recently had a teenage girl who was like, it's so hard. And so like Tina was saying, so shameful and struggling with it, and really wanted to connect with others who were going through the same thing to, see what they did. And then in terms of the doctors, I think, like it's hard to bring up. And I think it's especially difficult if you're not at a major center, but you know, like maybe doctors can ask these questions if they have, you know, some of the risk factors or are showing symptoms of that kind of, you know, disease.
Yeah, and in some centers also, patients usually tell that to the nurse and not to the physicians, and then the nurses come over to us, and because they feel more, more comfortable by saying that. Jeff, let's go back to you.
I was just gonna agree with you. That was what I was gonna come up and say. Your nurses are really good at developing relationships with patients, and also your advanced practice providers who also will spend a little more time and have the time maybe to spend with these patients to do those kind of things as well, and refer for psychological help as needed.
Yeah, fully agree. So let's go back to Jeff.
So yes, a question for Elsa and our surgical colleagues. So can you just give me a better understanding of the 2Bs that downgrade to a 2A? So who are these patients? Is it so I'm guessing that the reasons, predominant reasons why they wouldn't be an operable candidate, they may be an anal canal stricture, may have anal inflammation, may have more than one internal opening, that they wouldn't be a candidate for an advancement flap or a lift. Is it possible?
It's a really good point. I'll let Janindra and Paolo and Amy comment more than me, but I think it's the biggest problem that gastroenterologists have is that we just kind of go round and round and round, treating with biologics, never even offer this option to patients. And it was only sitting doing joint clinics with Janindra and other colleagues that there were some fissures that were clearly, curable with the right surgery at the right time. So I think it's kind of, again, I'll let Janindra and Paolo comment, but it is the anatomical ones which have got the possibility of something being done about them. But this is an educational piece, I think, for gastroenterologists to really understand suitability for surgery and when is our push point that we get these patients to the surgeon.
So I think pretty much all of the ones you mentioned will probably not go from 2B to 2A. Because if you've got anal stenosis, they're already in a fair bit of trouble. If you've got a lot of proctitis, they're already in a fair bit of trouble, and that's where the medical treatment comes in. Where the 2Bs that are actually ones that could probably become 2As are when you start to have multiple either intersphincteric or extrasphincteric tracts that haven't been dealt with, because the problem has always been that in the past, what people have done, because we haven't had this very good connection between imaging and understanding what at the operating table, understanding what that imaging actually gives to where you have to go and so on. And then we've got other techniques such as the video assisted fistula treatments, which means that some of those things that we used to just use our finger to try and do or make massive holes and so on and so forth, we can traverse through that to actually find it. So we have a better system, if you like, to actually try and control some of those external tracts. And that's why I think, and it'll come a little bit more in my discussion later on in the day as well, but this whole concept of having sort of the joint clinics and all of those things are really important, because we've got it there right as a together team, and that makes it much better for the patients as well, because it's not like the gastroenterologist says one thing, the surgeon says another thing, and there is no communication, whereas this is sort of straight in the middle.
I think maybe this is one of the most important educational pieces that we can provide with this group, and that is, as Elsa mentioned, educating gastroenterologists when it's most appropriate to refer to surgeons. And I think if you look at our medications, even if you look at the post hoc analysis of our new medications, we haven't made any ground on success rate with our treatments. And I think it's identifying those patients early for surgical closure techniques. As gastroenterologists, we often don't think about this, and I think this is one way that we can make a better dent into making people improving long-term outcomes. And so I think if we can identify to gastroenterologists who should be considered upfront rather than purely as salvage procedures, I think that's going to be important.
Yeah, I
Yeah, so
couldn't
we have
agree
to wrap
more. I
up.
think
Sorry,
similar to
go
the
ahead.
way that we've changed in terms of our medical therapy approach of going from, waiting for disease to progress and then treating patients to a more preventative approach. I think the same thing on the surgical side is the earlier we get them, even if we don't necessarily take them to the OR, but if we do take them to the OR and we're just cleaning out the tracks and doing a good exam, I think the earlier that we can get them in their disease course, the better the potential outcome. So more of a preventative, get them to us early, even if we don't end up taking them to the OR. Like, it's okay to send them to the surgeon to at least have that, physical exam and conversation with the patient.
That's an excellent point. So earlier, the better. So we have to wrap up. It came to our time. I think the main message from this part of the discussion would be that we need to work together, surgeons and gastroenterologists and nurses and also radiologists, in order to try to wrap up with the best for our patients. I think this is probably the main issue here in this session of classification and identification. So I give the word to Zoe, and I think we have a long break right now.
On that, so I'll keep it brief. So in terms of the surgical management really varies because this patient population is very heterogeneous. So the patient on the left that's relatively asymptomatic, single tract, not draining much, is going to require very different management than the patient in the middle with clearly multiple tracts or kind of this watering can perineum, as compared to the patient on the right that also has anal canal involvement and may have an element of incontinence. And so the phenotypes, and I know that Elsa touched on this with the classification system, really require different surgical interventions. So just to kind of keep that in mind as we go through this talk. And the majority of our patients will come to surgery. That's what we talked about first thing this morning. And the reason for that is that despite a lot of medications available and more medications being improved now in the small molecule inhibitor classes, the challenge is that there really is an anatomical defect, and that probably starts with ulceration that burrows its way through. And we also talked a little bit about pathophysiology, but there is a hole essentially that needs to be closed. And after patients have chronic disease, that hole in that whole tract can become really epithelialized. And so to expect medication to close that is not very realistic. So most of these patients require a surgical intervention. So what are the common things that we do? So one of the most common things that we do is an incision and drainage of an abscess. And if a Crohn's patient comes to a surgeon with a perianal abscess, that patient warrants an exam under anesthesia to look for a fistula tract, because most often in Crohn's disease, not necessarily cryptoglandular, but in Crohn's disease, patients with a perianal abscess likely have a fistula tract, which really requires a better look and then possibly placement of a ceton. And so ceton placement is obviously one of the most common things that we do. This is a common referral from a gastroenterologist in terms of a patient has perianal disease. Perhaps they're going to be initiated on a biologic. And before they do that, they would like ceton placed for better control of perianal sepsis. So the idea of ceton placement is basically to control perianal sepsis and potentially bridge to a more definitive therapy in an optimal situation, a more definitive surgical therapy. But it's really to control that sepsis so that we can optimize medical management. And the question often then becomes, when can we remove these cetons? Because patients would like them removed, understandably. And that is the thing that I think is more difficult to answer. And maybe we can have some discussion around when to remove cetons, when that is appropriate. Sometimes I think that we leave cetons in probably too long. And, one thing that might point us in that direction of leaving them in too long is actually what we're seeing in the placebo groups in the Admire trial, is how high the rate of healing can be. So I think that warrants further discussion in the discussion section. In terms of fibrin glue and fistula plugs, I think as a community, we've largely abandoned this as a treatment option because we have not seen good success with any of the plugs nor with fibrin glue. So I think that while there are not adverse effects to using glue or plugs, as a community, we really don't use this because it doesn't really work. In terms of a fistulotomy, so in our Crohn's patients, we don't use this technique very often. So even though success rate is great when we do a fistulotomy and patients heal after this, you have to be very selective of when you use this. So I do not do a fistulotomy if patients have anal canal involvement, if they have classic skin tags, if they have anal fissuring, obviously. So this is really for a patient that has no luminal disease involvement, has one tract, that it is very distal, does not involve the sphincter. So something that is possible in the right patient, but again, we're not going to see a lot of patients where this is the right treatment approach. In terms of a mucosal advancement flap or a lift, a ligation of an intrasphincteric fistula tract, both of these operations have healing rates in Crohn's disease of around 60%. This is a video of a lift actually from Phil Fushner at Cedars. So both of these techniques, and it depends really on kind of surgeon preference and experience with this, do have relatively high healing rates up to 60%. There is described incontinence, but the incontinence risk is very low. Described rates have been up to 10%, and a lift that has been generally lower in the series that have been published, somewhere around 0 to 5%. That risk is very low if it's with a surgeon who is experienced. There should not be a actual meaningful risk of incontinence, but it is possible. The challenge with both of these techniques is that really we can only use this in the setting of one tract and no proctitis or anal canal involvement. Now, if someone has two tracts, you can think of a staged approach, but in general, a lift or a flap is one tract and no proctitis. So again, limited patient population, limited phenotype where we can actually use this. So patients with proctitis, how does this change management? Well, in a patient with proctitis, we are limited. We are probably not going to do a fistulotomy unless the absolutely right patient. We can't do a mucosal advancement flap. Lift is often not used. And so a patient with proctitis, we are really trying to optimize their medical therapy and get them under good control. But if we can't get their proctitis under good control, then we have really limited ability to definitively close fistulas surgically in the setting of proctitis, or in the setting of patients with really chronic disease and multiple fistula tracts. So these are the patients, proctitis, multiple tracts, chronicity, lack of getting adequate sepsis control. These are the patients that are really getting diverted or having a proctectomy. So we know that our surgical rates of proctectomy in perianal Crohn's is still around 20%. I know David mentioned this earlier. And there's another 20% that are getting temporarily diverted. Although we know from the large series and from the systematic reviews that patients who are diverted, that restoration of intestinal continuity is usually not successful. So around 13% it will be successful, but the other 87% it is not. So the temporary ileostomy diversion is usually becomes a permanent solution to these perianal fistulizing disease. And so this is really where we have, thought that maybe stem cell therapy could come into play. And so I'm just going to touch, kind of high level on stem cells and what we know about this. Cell therapy has come really from adipose tissue or bone marrow. It's not particularly new. Garcia Olmo really pioneered this effort back in 2003. And what we've learned to date from a lot of clinical trials that have now been done, phase 1, phase 2, and now phase 3, Admire 1 was completed a few years back, and obviously Julian can speak to that. Admire 2 was just recently completed in the States, and we have some high-level data on that. But what we have learned from the studies of MSCs are that we understand that these are safe. So when we look at treatment versus control groups, yes, patients have pain. Yes, patients will develop an abscess, but this is really related to ongoing disease activity. There's no difference in the placebo group versus the treatment group. So related to Crohn's disease and related to an intervention, not related to investigational product or MSC. So we've seen that this therapy is very safe. In terms of efficacy, reported rates of efficacy have been somewhere around 50 to 85%. So when I have patients that are asking me, what can I expect in terms of healing, I will typically quote those rates. The 50% really comes from the Admire 1 data, which found a statistically significant improvement in the treatment group over placebo at 6 months and at 1 year in a combined composite endpoint of clinical and radiographic healing. The 80% healing has really come from some of the single center series. Garcia Olmo has done some phase 2s reporting that result. We did a couple phase 2 trials at Cleveland Clinic, of which the perianal phenotype, we had an 83% healing at 6 months. It's unclear whether that delta and healing rate of 50 to 80% is related to the actual investigational product, to the technique, to the patients included, because there's been some heterogeneity in trial design and product used. So that's just what I report to patients is between 50 and 80%. We did run some phase 2 trials at Cleveland to look at mesenchymal stem cells in alternative patient populations, meaning alternative phenotypes. So we had the perianal protocol, which included patients that were not included in the big phase 3 ADMIRE. So patients that were diverted, that did have severe proctitis, that did have anal canal involvement. And we found that healing remained at pretty high rate despite proctitis or other patient factors that had been excluded from previous trials. We had a rectovaginal protocol, which had 20 patients, of which 50% healed. We had a pouch fistula protocol. Healing rates were much lower in this protocol in the pouch fistula. But when we separated out the patients that had vaginal involvement versus perianal, the vaginal involvement patients actually had 0% healing as compared to perianal, which was 57%. And then we had a pediatric protocol, which patients did very well. Now, the challenge with all of this data is we were very excited after seeing the ADMIRE 1 results and very excited after seeing some of these phase 2 results as that this might be an option of just simply doing a direct injection where there's no risk of incontinence to patients in these severe phenotypes. And the great advantage of the no risk of incontinence, as we touched on this morning, is that some of our other surgical techniques do have somewhat of a risk of incontinence. We have also tried to really simplify this technique so that we can use it in patients with proctitis. We can use it in patients with anal canal involvement because it's really just a simple technique of closing the internal opening and doing a direct injection. And I'm just going to show a video here of kind of what that looks like in the operating room. This is a pediatric patient who did not have very severe involvement and had a single tract. And so what it looks like in terms of actually doing the delivery is that we receive cells. We have to check that their temperature is not deviated on transport at any time. Sometimes the cells can be a little clumpy, so we have to kind of gently agitate the vials before to get them back into single cell suspension. And then the back table setup is supposed to be relatively straightforward. We don't use betadine or chlorhexidine prep because we do know that kills cells. So we just use a normal saline or baby shampoo. And the table setup should be simple. It's just a little bit of prep, some curettes, some fistula probes, some lighted retractors. And the idea is that we close the internal opening. So we have that fistula probe through the internal opening. Extensively curette out the tract before doing this. And then we inject around a third of the product at the internal opening and 2/3 around the external opening. But again, the idea was to create a technique that we could use in patients with proctitis, with multiple tracts, where we can't use the other surgical techniques that we have, like a mucosal advancement flap or a lift. So that was really the purpose behind cell therapy is can we find something that is non-invasive of low risk that we can use in these other phenotypes. Now, we did hear recently, and we don't have all the data to present, obviously, but we do know that the ADMIRE 2 trial, which was done in the United States and Canada and some other sites to hopefully get FDA approval because Alofisel is approved in the EU. So the idea was to get approval over here in the States. We did learn that, unfortunately, this was a negative trial and the placebo and treatment rates were equivalent. And I think this is going to open up, for future discussion as trying to look at the data and understand subgroup analyses. But I think that this will, certainly raise questions about the utility of MSC therapy going forward and how we'll design future clinical trials. And so I think also maybe we'll have some discussion on that in the group at the end. And so really just some take-home points. We've talked a lot this morning about how this is a really difficult to treat phenotype. I think that getting patients to the surgeon for evaluation early, as we also talked about, before they have progression of disease in an ideal world is advantageous for us to at least start the conversation and really try to control the perianal sepsis early. I think that putting cetons in to achieve control and prevent sepsis can be a good thing, especially as we're initiating patients onto medical therapy. But I think there should be more conversation about when we remove cetons, because I think sometimes we leave them in place too long and sometimes the tracts can epithelialize. So I think, again, it's really working with the gastroenterologists on where the patients are at with their luminal disease involvement and what we can do for them surgically. We have different surgical options, but a lot of times our hands are tied just based on the fistula anatomy and underlying disease process. So the things that we have that probably have the most benefit in terms of achieving true fistula closure are the flap and lift. But again, we really can only use those techniques in a limited cohort of our patients. And so it's those patients with rapidly progressive disease or multiple tracts or proctitis that we're still really looking for new therapies other than just putting cetons in and leaving them in place. And so I think that is where stem cell therapy could have a role. I think it will be interesting to see all of the data from ADMIRE 2 to better understand that. But just to keep in mind, there have been a lot of studies which have shown statistically significant benefit and also some of the open label studies that have shown benefit. So I think that we still have more work to go on cell therapy. And I think I look forward to the discussion on that. So I will stop there.
Excellent. Thank you, Dr. Leitner. Our next speaker is Dr. Kochar, who is a gastroenterologist and division chief of the Department of Gastroenterology and Hepatology at Allegheny Health Network in Pennsylvania. He specializes in interventional inflammatory bowel disease and advanced therapeutic procedures. His current research focuses on endoscopic management of IBD complications, artificial intelligence in healthcare, and newer endoscopic innovations. He has been successfully published in leading gastroenterology journals, including Gastroenterology, Clinical Gastroenterology and Hepatology, and Gastrointestinal Endoscopy. He has more than 100 publications, including peer-reviewed articles and book chapters, and he serves on the editorial board of the journal Inflammatory Bowel Diseases. So, Dr. Kochar, when you are ready, you can share your screen.
Good afternoon, everyone. First of all, my apologies. I couldn't join in the morning. I'm actually in Milwaukee, Wisconsin. Don't go on my background. It's very cold here for another GI meeting. But I'm very honored and thrilled to be part of such an esteemed panel to discuss such an important topic. So I'm just going to briefly touch upon some of the endoscopic approaches that we have available for perianal fistulas in Crohn's disease patients. These are my financial disclosures. I'm sure we've all addressed this since morning. You know, fistulas is a big problem. So anytime, whenever I get an invite for a topic, I'm like, okay, why are we talking about this? It's a major problem in Crohn's disease patients. Perianal region is the most common location, obviously has very difficult management because of the location itself. So in this talk, you know, if you see my circles for medical and surgical management are equal size, but for the endoscopy, I've kept it smaller because I think still the leading way forward of managing patients is medical and surgical approaches. Endoscopy has to play a little bit of a role of an adjunct to medical and surgical therapies, and we'll see how does that happen. So in my mind, whenever I see a patient with fistula and they want me to do consider endoscopy, my goals are very simple. I want to aid in diagnosis of, perianal fistulas. We need to reduce the fistula-associated drainage, decrease risk of abscess, again, serve as an adjunct to medical and surgical therapy. And for me, the biggest one in discussion with the surgeons is, can we space out the need of the surgery safely in these patients? So in regards to the endoscopic diagnosis, MRIs are very good. EUAs are, I think, they have to be done. There's no question. But sometimes, despite these modalities, we're not able to pick up fistulas. That's where the endoscopic ultrasound can be really helpful. A lot of the work in this field, most of the work in this field has been pioneered by David Schwartz. And this actually next video is courtesy of him. That, sometimes when fistulas are not straightforward, we can easily pick them here. You see the hyperechoic shadow, right, rising up along with the air tracking. That's the fistular tract that sometimes can be missed, and your EUS can really help you diagnose that. And it's very important to know, because if a fistula is missed in the earlier stages, which might be a simple short tract fistula, can later on become a complex fistula, as we saw in Amy's talk, how some fistulas can be, very horrible and very difficult to manage with all those very nice pictures and videos. So in this one study, actually, again, Dr. Schwartz, as I said, was a pioneer in this field. They compared endoscopic ultrasound with MRI and EUA. Actually, all three methods are great. But if you were to combine any two methods, EUA and MRI, or EUA with EUS, I think you can actually increase the accuracy up to 100%. Because even in 10 to 12% cases, EUA sometimes can miss the fistula. So depending on which center you are, MRI can be tech dependent in certain places. MRI sometimes is not available. So if you have a good endoscopist who can do an ultrasound, which seems to be available readily, this should be considered. Fistula therapy. So again, very important to understand what are the principles of fistula therapy. We need to understand the etiology of the fistula. The drainage of the abscess has to happen first. We have to open the fistula tract, close the feeding site if present, and then figure out a method. And I say figure out because I still don't know the right answer of how to fill up the tract or do the epithelial debridement in these patients. So these are various options that have been tried endoscopically. We obviously won't go through all of them given the the time constraints, but we'll touch upon a few of them. Injection of fibrin glue and plugs, as Amy had mentioned, this is sometimes simple, can be performed, but we are not doing this anymore, and because majority of these patients still end up requiring other form of therapies, and it's not successful. I mean, it's like a flip of a coin. Less than 50% of the patients may benefit from it. So we have kindly moved away, and as Amy rightly said, no hard stops of why you can't use it, but it's not going to help your patients. Endoscopic clips, we gastroenterologists love our clips. These are some of the clips that I showed pictures in here. I have no conflict of interest with any company, but there are through the scope clips and over the scope clips that have been tried to close the fistulas. And when we specifically look at the perianal fistulas, these are some of the studies that have looked at the over the scope clip delivered by with the proctology set by the surgeons. And they report high success rate. But in the comment section, if you look at this, all of these studies, they had perianal fistulas, but the IBD patient number were very small. And in IBD patients, healing with even clips is very difficult, even with the OTSC clips. There is obviously the clip migration that you have to kind of encounter. Pain in the perineal region is a big problem. So that's why these have not taken off in the IBD field as much. Obviously, there is more studies going on in regards to the crypt gland or fistula of using these clips. In my personal opinion, again, this is not a data-driven, but in my personal opinion, yes, clips are easy to use. You can have high immediate technical success rate, but there is a very high failure rate as well. There is definitely an issue with tissue grasping. Tissue inflammation, especially in Crohn's disease, where transmural inflammation is a big problem. And perianal location is very hard. We all know, and it's not easy just to localize it and put a clip in there. And even if you put a clip, patients can have a lot of post-procedure issues. Endoscopic vacuum therapy. This is something that has been tried and tested in patients with bariatric disease-associated fistulas and other esophageal fistulas. One study looked at vacuum disease. 47 patients, 24 went vacuum therapy, and they reported at the end of 6 months, 75% of the patients had fistula closure. This is one study that we can actually rely upon and build upon this, because this was all Crohn's disease patients with perianal fistulas. The control group only had standard of cares, which was ceton. So vacuum therapy in conjunction with ceton is definitely something that we can look forward to in future. Fistulotomy, Amy did touch a little bit about it, but so endoscopic way of doing fistulotomy is the same as surgical way. You basically use a knife and you incise the fistulous tract. As Amy pointed out, should be used for simple fistulas with short fistulous tract. Now, most of the time, fistulas can be associated with a stricture, and this diagrammatic representation shows that if you can remove the stricture endoscopically and you can make the lumen one, you can improve the drainage symptoms associated with the fistula. So again, important to understand the etiology of the fistulas in every case. This is a representation video for fistulotomy. This is exactly not perianal. It's a J pouch fistula, pouch body to body fistula, approximately 2.5 centimeters above the above the anal transition zone. Patient had, symptoms consistent with pouchitis and oral abscess ulcerations, was transitioning off medications, but somehow the fistula was missed. So in this, we basically just, again, use the electroincision knife towards the lumen side. We want to cut the fistulous tract. As we saw in the schematic diagram, the idea is to make the fistula lumen one with the lumen. Now, this becomes very hard exact at the anal canal location because the pain fibers and the bleeding risk, but can be considered based on where the location is exactly. So as we see, we just completely incise the fistula. It made, one with the pouch body. We use clips in the end to close it. This was the 1-year follow-up. We just see a little bit of a area, and then the 2-year follow-up, there was no fistula tract and everything was fine. So we published our experience in this. We had 29 patients, 26 had a pouch-related fistula, 3 required surgery, 26 patients. We successfully closed the fistula with fistulotomy. There was 1 patient with a significant post-procedure bleeding. Again, endoscopic fistulotomy should be attempted in short fistulas, simple straight fistulas. Again, this should be a tool as an adjunct to your medical and surgical management and not should be a management on its own. Seton placement, generally this is done by surgeons, but again, not every center has IBD surgeons or colorectal surgeons. So this is one way that you can endoscopically also place a seton. This is during my fellowship when I was with Bo at Cleveland Clinic. We had a patient with the perianal fistula that we found the tract, and you can see the pus oozing out. The technique is exactly similar to what our surgical colleagues use. We passed a guide wire and we identified the fistulous tract. You can see the pus coming out. The seton was attached to the guide wire along with the suture, and then the guide wire was pulled through. Again, I think this is I'm lucky where I am. I have 5 or 6 colorectal surgeons. We refer them routinely, but if the surgeon is not there, patient is on the table, fistula is relatively simple to find. This is something to keep in the back of your mind. This can be done. It's not a very complex procedure, but again, better done by surgeons under EUA guidance. But we have described this, and then pretty much the standard, you just tie the suture. So lastly, the future tools in regards to endoscopy, we've seen the evolution of full thickness suture system for a while. It again has not been able to be successfully closing fistulas in IBD patients. For non-IBD patients, it has done really well, but there is a modification of this system, and now we have what we call as an X-TAG system. The representative diagram is below. This is something that goes through the scope, so you don't have to use a 2T channel scope, and this actually seems to be able to deliver the sutures very precisely in very tight locations. So this is something we might see in the future coming. People trying to use this, but again, the goal is to drain the abscess first and then close the tract and not vice versa. And another thing that has started gaining some traction, and there were at least 4 case reports when I last reviewed the literature, was using of the cardial septal occluder device. These are devices that we use to close, ventricle septal defects in children, and they have been successfully deployed to close fistulas. Again, non-IBD fistulas tend to do very well, but in IBD patients, there were only 4 case reports. And I think we have to also understand that the short-term technical success doesn't guarantee long-term fistula healing. So I think we really have to be cautiously seeing as to which therapy helps. But sometimes these little breaks from the fistula management can help our medications catch up, and other innovations like hyperbaric oxygen. That's something I use a lot in my patient population, catch up to help with fistula healing. Amy touched a lot on stem cell therapy, so that was something we still hope that in the future, like our European and Asian colleagues, we might be able to use more. But I just realized that the ADMIRE-2 study was negative, so we'll see how that spans out in the future. So in conclusion, it's a complex problem. We all know that's why we all gathered across the globe here today. I think knowledge of anatomy and disease state is very important. And the biggest key is a multidisciplinary approach. For endoscopic management, I will still target short and simple fistulas, and very knowing the limitations of endoscopy, that it has to be used as an adjunct to medical and surgical approaches. I think that's a discussion with the patient that needs to happen, so that our surgical and medical colleagues can optimize the management of the same. With that, I would like to thank all the organizers for this meeting, David Schwartz, Tina, Amy, for giving me a chance to come and talk to you all. Thank you so much, and looking forward to the discussion. Thank you.
Thank you, Dr. Kochar. And our next speaker is Dr. Penes, who is Senior Investigator at IDI-BAPS in Spain. His research group is focused on the development of new diagnostic tools, particularly imaging modalities, the identification of new molecular targets for treatment of IBD, and the development of cell therapies. He's published more than 400 manuscripts in international peer-reviewed journals, has served as a member of the scientific committee of the United European Gastroenterology Federation, the Scientific Committee on European Crohn's and Colitis Organization, and has been a member of the board of International Organization for the Study of Inflammatory Bowel Disease, Associate Editor of Gut, and President of ECHO. Dr. Penes, when you are ready, please go ahead and share your screen.
Maybe unmute.
Dr. Penes, we can, yeah. Can you unmute? There you go.
Apologies for that. Okay, now you can see the full screen.
Not yet.
Not in presenter mode.
Sorry?
We see the other slides. It's not in presenter mode.
Okay.
It's okay, though. You can present in that mode.
You can. Sometimes
let me make a last try, because sorry, I don't want. That's my. Okay, I will go ahead with that. Okay, first I have to start with a warning. There are few scarce prospective randomized controlled trials on medical therapies for perianal fistulizing Crohn's disease, and therefore the data is mostly based on case series and retrospective data. So it's low quality evidence for the majority. And let me start by mentioning what should be avoided. There is not extensive recommendation on the use of corticosteroids or aminosalicylates in recent guidelines. They are not mentioned in the AGA or in the ECHO most recent guideline, but a consensus on the classification, diagnosis, and treatment of perianal fistulizing Crohn's disease published in 2014 stated that there is no demonstrated role for aminosalicylates or corticosteroids in perianal Crohn's disease, but there is even more. We know that corticosteroids may worsen perianal fistulizing Crohn's disease, they may worsen discharge, and may lead to an increase in surgery requirements. So corticosteroids should be avoided in the context of fistulizing perianal Crohn's disease, something that is not commonly followed in clinical practice. The evidence for the efficacy of antibiotics is again weak. It comes from very small sample trials. And the first randomized control trial was published by THEA in 2009. It includes only 25 patients, that were randomized to Cipro, Metro, or placebo. There was no difference, statistically significant difference between the 3 treatment arms. But recent trials that looked at the potential combined effect of antibiotics, in particular ciprofloxacin with anti-TNF, they showed that both for infliximab and adalimumab, the response rate was increased for infliximab from 39 to 73, for adalimumab 47 to 71% in the first weeks of treatment. So from this, based on this evidence, the AGA suggests against the use of antibiotics alone over no treatment for the induction of fistula, but might have a role as an addition to anti-TNF therapy.
Sorry, Julian,
Yeah.
your slides are not advancing, I believe. Your slides are not advancing for us. We're still seeing the warning slide. Now it goes.
Yeah, perfect. That works.
Now, okay, so okay, that was the AGA recommendation. Now you are seeing thiopurines?
Yep.
Okay, apologies again for that. There is no prospective control trial on the role of on thiopurines on fistula outcome, and the data comes from meta-analysis of subgroup analysis studies showing that the fistula healing rate under thiopurines was 54% compared with a 21% under placebo with an odds ratio of 4.4, and the association of azathioprine to antibiotics were more likely to achieve response than antibiotics alone. But still, the ECHO guideline suggests against the use of thiopurines as monotherapy for fistula closure in patients with Crohn's disease. Note that the stepping stone of treating of medical treatment of perianal fistulas in Crohn's disease is anti-TNF, and in particular infliximab, and this is based on the landmark results of the trial by Present, published in now almost 25 years ago, showing that infliximab achieved a higher number of patients responding, closure of 50% of the draining fistulas, or complete closure, 46% versus 13%. The results were very clear, a large delta between active arm and placebo, and that was followed by the study by Bruce Sands, showing that in responders to induction with infliximab, maintenance with infliximab achieved sustained closure at week 54 in 36% of the patients compared to 19% in placebo. But still, if we look at the overall population that entered the study and received induction therapy, it's equivalent to only 23% of the induction population. For adalimumab, initially there were small trials evaluating the response at 4 weeks, but data from the CHARM trial evaluating the response at week 56 again showed that adalimumab achieved closure in 33% of the patients versus 13% of placebo, and continuing adalimumab over 1 year led to sustained response. But still, we achieve our goal of complete closure in only 1/3 of the patients with the best medical treatment we have, the anti-TNF. Can we improve that? Well, data looking at the relationship between drug levels and therapeutic benefit, we observed that fistula healing in patients with fistula healing, infliximab levels were significantly higher, 15, compared to the group of patients with no healing, 4. And when in the graph on the right side, you see that there was a progressive increase in the proportion of patients that achieve closure in red bars, going from 7% to more than 40% as we increase infliximab levels, and there is a kind of shouldering at levels of 10 and above. So that might be a practical target level for managing infliximab. And Amy mentioned before the importance of ceton removal. And here you see in the right, in the graph on the right, in the continuous line shows that by removing the ceton between 5 and 12 weeks after it is placed, it achieves, in combination with anti-TNF therapy, better results than having the ceton in place for longer periods of time, 8 months or more than 8 months, the dotted and dashed lines. So it seems that early removal of ceton is part of the optimization of therapy. And maybe this is one of the most important recent results, the PISA-2 trial that has been recently published, comparing anti-TNF therapy sustained for 1 year with surgical closure using flap or lift in combination with anti-TNF therapy. I think that we are entering really in many aspects of treating IBD in the era of combination therapy, and this is an important combination of surgical closure plus anti-TNF versus anti-TNF alone. And here you see that in terms of radiologic healing, MRI healing, the combination therapy in blue achieves significantly higher rates of radiologic healing than anti-TNF alone. There was a trend, although not significant, for clinical healing. And very importantly, the surgical reinterventions were significantly lower in the group of combination therapy compared with anti-TNF alone. Other drug classes, in particular anti-IL-12, anti-IL-23, ustekinumab, have shown promising but still not significant results. This is the results and overall analysis of results from Certified Unity 1 and Unity 2. You see that there is a trend for ustekinumab induction to achieve better results than placebo, although that doesn't reach statistical significance. Again, this is a sub-analysis of the population with fistula included in those trials. And in the left, you see that maintaining ustekinumab at week 22 achieves better results in terms of improvement in fistula response than placebo. There is one dedicated trial of vedolizumab in patients with fistula that published by our colleague David, and there is no placebo control, and David compared here the classical induction regime of 0 to 6 followed by every 8 weeks with an additional injection at week 10. There were no significant differences between the two induction regimes, and if you look at the overall, the pooled vedolizumab efficacy, it achieves similar closure rates than the anti-TNF, although importantly, we don't have a placebo control here. And just to finish, a couple of mention of two other potential therapies. We know from the pathway analysis of genetic associations with perianal Crohn's disease that the JAK-STAT signaling pathway is the one that has a higher number of genes involved. And the first results of upadacitinib in the treatment of perianal fistulizing Crohn's disease, again, a sub-analysis of patients with fistula included in the pivotal trials, showed a benefit of upadacitinib over placebo for obtaining fistula closure and complete resolution of draining, and the fistula closure during maintenance was also observed in a higher proportion of patients treated with UPA, 50 or 30 milligrams compared with placebo. My last slide is to summarize the results of a completely different approach, non-drug approach, is hyperbaric oxygen. There has been repeated and very small trials looking at the potential efficacy of this therapeutic maneuver. And for perianal fistula, the results were promising with an overall clinical response of 89% and clinical remission of 65%. However, this therapy did not achieve a benefit in rectovaginal fistula, 29% of patients responding. Probably the best summary of all this evidence is the recommendation of the AGA to use biologic agents with a strong recommendation for infliximab and a conditional recommendation for other mechanisms of action, in combination with antibiotics over biologic alone for induction of fistular remission. And ideally, we should combine that with an appropriate drainage at baseline, removal of cetones after 2-3 months, and probably surgical closure of the fistula tract. With that, I thank you. And again, apologies for the messing up with the presentation.
Thank you. And we are now moving into the discussion portion of the session, and Dr. Leitner is moderating.
Thank you. We'll try to keep this, I think, to 20 minutes, given we're a little bit over time, but I didn't know if anyone wanted to start out with any questions in particular. I know there's been some questions in the chat. I see a couple hands up. Jeff, you want to start?
Sure. So can we have a discussion about cetons? In the scenario where patients have a new diagnosis of perianal Crohn's disease, where the intent is for healing. So complex fistulas, I completely understand how we want to achieve drainage, but cetons, the data out there is maybe non-existent as to cetons being beneficial over anti-TNF alone. Some of the original studies or meta-analysis that looked at this lumped in combined therapy versus either anti-TNF or either surgery alone. And so we're looking at this right now, and it looks as though if you separate patients by those where the single modality therapy was anti-TNF, you compare that against where the single modality is surgery, it looks as though the combined therapy is really beneficial when compared to surgical drainage alone. So do these patients require cetons? And if you think about maybe a foreign body reaction, the epithelial to mesenchymal transition, and the fact that many times when cetons go in, they're not removed quickly, as Julian had mentioned, I think it's very important. So are we possibly doing a disservice? And is this creating a scenario where you do have the mature epithelialized tract that's never going to heal if cetons are going in too long? And so I guess the question is, we probably can't answer this here because we don't have the studies, but maybe in our messaging, I want to hear what other people feel, but are we potentially doing a disservice by universally putting cetons in for our patients, and especially if we're not taking them out early?
So I think those are really, really good points, and I'll have Janindra and Paulo weigh in here too. But I think you raise a really good question about, are we doing a disservice? And I think that the challenge that we're facing is it's a really heterogeneous group. So I think that it really, ultimately, it depends on the patient phenotype. But I agree, if a patient really doesn't have proctitis and maybe they have a fistula tract and you're going to initiate therapy, and you want to have a ceton before you initiate therapy, then there should probably be an aggressive plan to remove the cetons, and we don't do that. But that's very different than the patient that has really severe proctitis and we can't get their perianal sepsis under better control. So I think it's challenging to educate around this unless there's a lot of IBD experience, and because there's a lot of nuance to it. But I want Janindra and Paulo to comment on that as well. But I think really good question that's raised.
Yeah.
So I think.
Go ahead, Janindra. Go ahead, you first.
Sorry. So I think the question of the epithelialized tract is a really important point, because I don't think that removing the ceton or even the drugs will actually deal with the epithelialized tract, because that's almost like healing in a different way. So there is something that surgically we've got to do for that, whether you cauterize the tract, laser the tract, whatever the technique that's available and is good. in my opinion, needs to be done. And then you can think about removing the ceton, because I think the biggest issue there is that if you don't have inflammation, I don't think removing the ceton is going to help that much.
Yeah. So yes, I think the proctitis is the driver here. So if there's active disease, patients without symptoms equals abscesses, repeated abscesses, and this is something that we see often and often. However, I agree with your point, Jeff, that sometimes chronic symptoms can be a disservice because they can ruin the anatomy and they can cause fibrosis. They can even cause other problems. So I think individualization is key. We have to control disease activity, luminal disease activity in the rectum and also in the perineum, and try to take off the symptoms as quick as we can. But for that, I believe epithelialization of the tracts is needed. And you can only see that by, examining the patients often and often. This is just something I would like to point out.
Can I make a comment? Because I've probably been the biggest advocate for leaving in cetons longer term, and Amy and I were messaging about this a little bit, and I'm fully willing to admit that maybe I was a little bit wrong. But I do think there's a role for cetons, particularly in the early part in complex disease, and I think that what we need to figure out is when should we remove it? When is it optimal to remove it and close the internal opening? And you'll hear a little bit in my talk in the next session that perhaps this is where imaging can really help us quite a bit. And so not just physical exam, but maybe considering repeat imaging. And I'll talk a little bit about that in my talk coming up.
So can I just maybe ask Tina?
Just make a very quick point also. I think it also depends where are you practicing. In my practice, most of the patients have gone to some ED or general surgeon with an abscess. Ceton has been placed. They don't carry a diagnosis of IBD. Now they are referred to make a diagnosis of IBD. So I think sometimes that also hinders because they've already come to us with a ceton in place. But I think what I would love to see from Amy, Paul, and other surgeons is the messaging to the surgeons. We advocate sometimes, like I would say at 3 months, can take the ceton out, and surgeons are very hesitant saying, oh, well, what if the abscess occurs again? So I think this is a good opportunity for us to kind of enforce that point in the surgical societies that early ceton removal is fine. I agree with David. In my personal opinion, if I have a new fistula diagnosis, medical optimization and the center where I work, I'm lucky because we got hyperbaric oxygen approved for our patients, is covered by insurance. I love to put them in the chamber if patients are willing for 6 weeks. I think that achieves higher rates. Without ceton, I'm not very sure if medications alone can cut it.
So
no, Jordy's had his hand up for a little while. Jeff, sorry, I don't mean to cut you off. I just want to make sure Jordy has a point. He's been patiently waiting over there.
Sorry, wow. Can you repeat this, please?
Oh, you just had your hand up on the Zoom thing. I don't know. Maybe it was unintentional.
No. Yeah. I had a question that's not related to what was discussing now. It's a question about specifically for Julian or the other expert gastroenterologist. It's about the changing of the criteria for treatment efficacy in clinical trials. So by the time the simple clinical response was moved to sustained clinical response, now it seems that MRI has a room in assessing response, but for a while, MRI component of the co-primary endpoint was limited to lack of collections. And now I see that in PISA 2 trial was used the more stringent requirement that is fibrotic or healing of fistula tract. What do you think about these different criteria used in different trials? That is an advantage or a limitation for comparing treatments, or because
I think Jordi that we had of course the absence of abscesses higher than 2 centimeters. We also look at 1 centimeter and things didn't change. But this is not a healing of the fistula, clearly. The problem is that when we designed that trial, it was not clear we didn't have at that time, that more than 8 years ago, we didn't have at that time a definition of what was radiologic healing. Okay, so we knew of the prognostic value of having an abscess, so we adhere to that. We knew that if patients had an abscess, they would not do well. Okay, but we knew that the fistula tracts you could still identify the fistula tracts by radiology in patients with long-term closure. So we didn't know how to define that. Now we know which are the characteristics, and as you mentioned, we know when a tract is fibrotic, when it is closed, when it is when inflammation has already been resolved in the tract. And I think that we should adhere to these new definitions of radiologic healing, not just absence of collections.
When we had discussions with the FDA about the endpoints of the trial, it's a long time ago now, they just wanted to have some MRA endpoint, and that was the easiest one to include. So that's literally how it came about. So that's, we've obviously progressed quite a bit since then.
Or has Amy frozen?
Yeah, I think she froze. Go ahead, Elsie. I have your hand raised.
Yeah. So going back to your point, Jeff, about the seton removal. I just wonder again if it's how the framework that we think of this within, and things like the joint working with, Janindra and I working with the patient together, and the goal setting bit, and thinking of the framework of the 2A's or the 2B's. Immediately that starts the right conversation. That if we think we've got a 2A patient where the goal is to pull the seton, heal it, etc., then, and the patient really wants that, then that becomes the clear sort of passage of what's going to happen. If on the other hand, there's a patient who actually is quite comfortable to seton, because actually there are some of those patients who want that, and actually Janindra says, well, there's nothing we can do surgically here, and we know medically it's going to be a challenging one, then you might just err for it going in keeping it in for a longer period of time. So I think, as Amy said right at the beginning, it is the nuance of the different patient groups, but the sort of framework that the classification sets, and the joint working, the Janindra and I being in the same room at the same time with the patient, can kind of help to sort of help these decisions.
Yeah, that was going to be my comment, to maybe get Tina's opinion on that, because I think it's not just about us. It's patients have to make a decision. Do they want to accept maybe that the risk of abscess reforming, maybe it's more likely to reform at the potential advantage of increasing the likelihood of healing long term. And some people may be willing to take that risk, other people's may not. And I think our patients are going to have to help us out with that.
Yeah,
thank
Tina,
you so
maybe
much.
after you take this, you can hand it off to Gary, who's also on. It'd be interesting to get both of your guys' perspectives. I know you guys have both had long histories of setons.
Absolutely. And thank you so much for joining, Gary. It's good to have another patient on too. So I just wanted to share the several times I've had setons removed have either been done outpatient or in the OR, but I remember how much anxiety it caused me, because I was wondering, is there going to be abscess reformation? Am I going to have to go through this all over again? It was extremely traumatic to even think about having the seton removed, especially during that time. Like, I was retrying biologics. There weren't as many available. I think it was just Remicade, Humira, and Entyvio at the time, and Stelara was still in trials. So I think we have to weigh in the fact that patients are really traumatized by this, happening over and over again. And what does this mean for us? I think we're anxious about what is going to come and how much this is going to limit our lives again with regards to work and school and, just psychosocial aspects. But I also wanted to bring up another aspect of this is, one thing that I never got clarity on, and I would ask all the questions, but it was just not sort of engaged well, is, talking to my surgeon, talking to my GI, and trying to understand, what is the timeline for this? Okay, if there's no clear timeline, how are we going to make these decisions? I just did not feel like those conversations were happening. And I think when there is so much anxiety around a process that may not have clearly defined timelines yet, we need to have greater shared decision making and more clearer conversations between CRS, GI, and the patient and their family. Okay, so we don't have all the answers, but we do think that this could help you. We need to see if the biologic can kick in at this point and do its job, given that, we've done XYZ interventions with regards to the ceton. So I think some of these conversations need to happen in order to allay the fears and anxiety and, the re-traumatization, which I haven't felt like are happening enough, at least not in my case and in many of the patients that I've spoken to. And a lot of times, the patient will just be left with the ceton, even with visit after visit to the doctor. There is no sort of conversation. I've heard this a lot out of the developing world, is just the cetons are just left there. No real conversation about, okay, do you want to remove this, or how do we remove this, or what is the right timeline to do so? So I just wonder if we could do something in terms of having those clearer conversations and to encourage shared decision making. Excuse me.
Yeah, I think I'll jump in also now. First, I want to thank everybody for being here today. You guys do incredible work, and all the patients all around the world are greatly appreciative. So thank you. I have I'll do my whole story later on, but with respect to cetons, I've farted around with them for 7 years, and they really did not help. While with a ceton, I developed an abscess, which led to sepsis, which led to septic shock, which almost killed me. And the frustrating thing about cetons is it doesn't make sense to me, at least, that you seal a hole by keeping it open. There have to be better treatments out there. I've done them all over the years. So cetons, I think, need to be de-emphasized in all of this. I don't know that there's a really place for them. As a patient, I found them very frustrating.
That's an excellent point, Gary. If I may just, the idea when you place cetons from a surgical perspective is not to close the fistula, it's the opposite. It's to leave the holes open, not to have repetition of abscesses, and to provoke probably the epithelialization of the tracts. But if the hope of closing a fistula, of course, cetons, they need to be withdrawn. So I agree with you that probably we need to speak the same language on that, because the idea is completely the opposite. When we place cetons, the idea is not to close them, is to keep them open to drain, not to save infection. But the long term is the problem. I think the long term is where it creates some discussion.
Well, I also think, to Gary's point, that sometimes we put cetons in and patients can still develop an abscess or still develop progression of disease or still need diversion. So just because we put a ceton in doesn't mean we can just put cetons in and then walk away and assume everything is fine. Because we do have those phenotypes that have more progressive disease. And sometimes the way that we put cetons in and where the knots are, and if the cetons get caught and they actually get clogged in the fistula tract, that patients can develop abscesses. So I think it's just important to keep in mind that there can still be progression of disease even with cetons in place.
No, and I think what Gary's saying, I started to put it in comments, is, we really need more patient education as to why cetons are being placed, because it is a counterintuitive sort of intervention in our minds. And a lot of times it's not being explained. And I agree with you. Abscesses can certainly happen due to everything that you just mentioned, Dr. Leitner. It's happened to me. So it's very important for patients to understand these things and to make sure these conversations are happening.
What patients want is to be cured. They don't want to stay at the status quo, telling me we don't want you to get worse, so we're putting a ceton in. That's not very comforting. It's the cures. It's, getting to Dr. Leitner at the end of my journey with stem cells. For me, that was a cure. But it was a 9-year journey for me to get to her, and a lot of rough spots along the way. And I'm taking a list here of everything that I've tried. From Cipro to Remicade to methotrexate to cetons. I had doctors I had an ostomy and an ileostomy along the way. And none of them really did anything to cure, fix anything with my fistulas. So it's very frustrating. And there are literally in the States alone, hundreds of thousands of people who, put pads in every day and try to go out, and their doctors say, how many pads did you go through today? And, my goal was not to go from 8 pads to 4 pads. My goal was to go from 8 pads to no pads. And it took a very long time. And I'm one of the very fortunate few who have gotten there, which is a whole different story. But in looking at what you're trying to do today, it's figuring out how to get patients better. And that's what we want to hear.
We are now in our 4th session. What tools do we have and what do we need? And this session's chair is Dr. David Schwartz, he will do the first presentation, and then we have a panel discussion after Dr. Schwartz's presentation, followed by a group discussion. So Dr. Schwartz is our one of our members of the steering committee for this program. He's also a professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition at Vanderbilt University. He founded and currently serves as the director of the Inflammatory Bowel Disease Center at Vanderbilt University Medical Center. His editorial experience includes serving as section editor for the IBD Journal, associate editor for Gastrointestinal Endoscopy, and served as the select summary editor for Gastroenterology. His research has focused on clinical trials for inflammatory bowel disease, imaging of inflammatory bowel disease, the multidisciplinary care of the IBD patient, and the treatment of perianal Crohn's disease. He's lectured extensively throughout the United States and has written more than 300 articles, book chapters, and abstracts. So Dr. Schwartz, when you are ready, you can begin your presentation.
Okay, let's see if my computer will behave. How's that? Good?
Yes.
Okay, great. Okay, so I am sort of the appetizer to one of the most important sessions of the day. We're going to get to hear about sort of in design really, and have some recommendations for what is the ideal multidisciplinary team for patients with perianal disease. So before we get to that, I want to talk about maybe ways we can improve outcomes through imaging. And I realize some of this is going to be controversial, and much like some of the other presentations, we don't have a lot of data, but I'm going to kind of talk about what my thoughts are along this regard. And I will tell you, when I was part of the Toronto Consensus Conference, and when we proposed the idea of imaging patients with perianal disease, it was very controversial. It was a little difficult to get approved, but I think that was a big step forward. And I hope this is sort of the next step to help kind of improve how we take care of patients with chronic perianal fistulas or complex perianal fistulas. So we know, as I showed this before, durable fistula healing rates are disappointing. We have great medicines, but even with the most optimal use of those medications, we still have very disappointing long-term fistula healing rates, with only about a third of our patients with complex disease having complete closure of their fistula tract. And part of the reason why is that even in the most skilled hands, when you have someone that has really severe disease, scarring, induration, digital rectal examination is just really not very accurate. With that, we miss quite a bit of important findings on EUA and or in the office just on physical examination. And I kind of want to you to think about image improvement or image remission as the equivalent of mucosal healing for luminal disease. Not something that was controversial initially, but now is really sort of standard of care when we start advanced therapies for luminal Crohn's disease. I think we should be doing the same thing for our patients with complex perianal fistulas as well. When I first got here, we were starting to do some things looking at using EUS. I do EUS. I will fully admit that most of the stuff that we'll probably use in this country and worldwide will be more MRI related. And I'm not a radiologist, so I'll defer to Jordy as far as some of the things later on and what he would recommend we use. But for EUS, what we're looking for is more of a heterogeneous echo texture and the hypoechoic signal, which is inflammation decreasing and more closely approximating the diameter of a ceton that was placed at the time. And so what we did first retrospectively was we initially imaged patients with EUS, gave the surgeons a roadmap of what's going on that patient's bottom. They used that to clean up any sepsis that was there, and we optimized therapy. And then we followed them going forward using imaging to decide when to remove cetons, when to change therapy, etc. And doing so, in a small case series, we were able to really improve our long-term fistula healing rates or long-term cessation of drainage. And just to kind of show you what that looks like. So here is the ultrasound probe, the water-filled balloon, the anal sphincter, and here you can see a fistula track. After this, ceton was placed, medication was optimized. We brought that patient back for at week 16. Now that inflammation it's hard to kind of appreciate here, maybe it's more heterogeneous and more closely approximates the ceton. So we removed the ceton, and then we did a follow-up EUS at week 30, and all we could see is residual scar tissue. In this case series, this is before we really kind of bought into more maintenance therapy with our anti-TNFs. We use this as a way to determine when we would discontinue anti-TNF therapy. And in the 7 patients that had what we considered healing on EUS, none of them developed recurrent fistula tracts out to 2 years of follow-up. So I believe that was a true finding where we were getting scarring of the tract, and those patients did well long-term. And that led to a small pilot study where half the patients got EUS guidance, same methodology where they were imaged initially and then monitored by EUS. Treatment decisions were made based on the finding of imaging. At the end of the study, 4 of the 5 healed. The one that did not heal had the misfortune of having their ceton accidentally fall out prematurely. And in the control arm, which is surgical decision as to when to remove the ceton, when to optimize therapy, only 1 of the 5 had complete fistula closure. Just to kind of show you what some of the representative patients. This is the initial patient, inflammation, air within the lumen. This is the EUS probe. This is follow-up EUS after the ceton was removed. You have more heterogeneous appearance to the tract, and this is the final exam where there's complete fibrosis of the tract. This is the one patient that had the misfortune of having their ceton fall out prematurely. This is the initial EUS with an abscess. This is a midpoint EUS with the tract, the abscess cavity is healing. Ceton falls out, and then they develop a large abscess as a result. This led to a larger prospective study where half the group was followed by EUS, and then half the group was by surgical management or standard of care management. And you can see at 6 months, those that had image guidance to their therapy had a much higher fistula healing rate or cessation of drainage as compared to those that sort of used the standard of care decision as to when to remove cetons, when to optimize therapy. And we've done similar things in kids. This is ultrasound guided care in the pediatric population. Those that had the EUS guidance had a much better or more durable fistula healing rate in that patient population as well. So how about MRI? Have we done things with MRI? Well, we know from MRI that MRI can predict who's going to do well, who responds well. You can see that an early response rate at week 6, and those patients are much more likely to continue to be in remission during the follow-up period. And that improvement seemed to plateau after about a year on therapy. And people have used MRI similarly to how we're using ultrasound in our patient population to help inform treatment decisions. In this study, patients that were imaged at week 22 had no response. That led to dose escalation. It was usually going from biweekly adalimumab to weekly adalimumab to convert some of those non-responders to responders. So using imaging to guide therapy was at least beneficial in that small study. And we know that there is a discrepancy between clinical healing and MRI healing. So in other words, when we examine a tract, there'll be cessation of drainage well before we see image remission of the tract. In our ultrasound population, there was about a 3-month difference in healing between clinical healing and image healing, and there have been similar findings in the various studies. You can see in this meta-analysis, you had clinical remission in the short term in 47% of patients versus only 7% in the MRI group, and then more longer term, 42% versus 25%. So there's an important difference between those that have cessation of drainage and those that have true image remission, and that is, I think, an important point to determine in order to really optimize treatment. We can learn that from the PISA trial. So the PISA 2 trial, large trial, over half of them were in the TNF arm alone. In the 25 patients that achieved radiologic healing, most of those were in the surgical arm, some were in the TNF arm, but radiologic remission was defined as hypotense tract, indicating fibrosis, no increase in T2 signaling, and no enhancement in the tract with contrast on fat-suppressed T1 weighted imaging. Of those 25 patients who achieved radiologic healing, they were none of them, or they were able to determine all of them. 14 of those that actually were able to stop TNFs without recurrence, and all those patients achieved clinical remission versus only 36% of patients who still had persistent activity or were not in MRI remission on imaging. So MRI was able to determine which patients were going to do well long term. And another study looking at this looked at the outcomes in those that achieved deep remission on MRI versus clinical remission. And you can see here those that were in deep remission had a much longer flare-free survival rate as compared to those that still had evidence of activity on MRI. So to kind of think about this and how we might incorporate this into our clinical care pathway, we've heard that perhaps repeat MRIs may not be feasible everywhere, but certainly in patients that have more complex disease, this may be a way to help inform treatment decisions and also improve outcomes in this patient population. So think of this as, again, as I mentioned before, the equivalent of mucosal healing with luminal disease. So the way I would propose this be done is you have this initial assessment with imaging as part of that. We send those patients to our colorectal colleagues. We clean up sepsis, start therapy, and then we re-image. And I think this is where we need to figure out where it makes sense to re-image, because these are important treatment decisions. And so we want to wait long enough so that whatever treatment we have started has time to work, and not image too early, but then also not wait too long where we allow, maybe the disease to become active again or complications to occur. Those that have achieved deep remission on imaging, then great, we can stay the course. If we had left the cetons in, which I think you've heard maybe we don't want to be doing, we would remove them at this point. And those that have not achieved deep remission, this is the time where we can start to look at things that we can optimize, maybe optimize drug levels, maybe think about changing antibiotics. Maybe it's a fistula tract or branch of a fistula tract that we didn't adequately address at the initial EUA, but it gives us the opportunity to sort of pause, think about what we can do to convert some of these non-responders to responders in order to help better improve outcomes in this patient population. Again, I know this is not done commonly, but I think this is something that we need to think about to help improve outcomes. So unanswered questions, what MRI variables do we want to use to define remission? Is it T2 signaling? Is it lower MT ratio, no enhancement on T1 and weighted image? I think that has to be, still has to be clearly defined. And then when the optimal time to re-image patients are. The way we're doing it with ultrasound in our practice is we wait for that patient to tell us that the drainage has slowed down and it's become non-purulent. That's when I think there's the best time to make sure the medications are working optimally, and the opportunity to maybe intervene if they're not. That it generally is about 3 to 4 months in our practice, although can occur sooner in some patients. And then doing this, can we convert some of these partial or non-responders to remitters by optimizing or changing therapy? I think that's something that would be really interesting to study going forward. So thank you all for this. It's been I've learned so much today. It's been so far a great meeting. Looking forward to the discussion coming up.
Thank you. I am going to introduce our panelists for this discussion that Dr. Schwartz would also moderate, and we'll just kind of introduce everybody. So first is Tina Prakash, who was also on our steering committee. She is a multi-award winning Crohn's disease and ostomy advocate based in New York City. Tina maintains a blog and advocacy platform called Own Your Crohn's, and co-founded South Asian IBD Alliance to form a patient clinician-led nonprofit organization in order to minimize stigma and disparities while improving education and awareness in the growing South Asian IBD population. Tina graduated summa cum laude with her master's in public health in June 2023. Congratulations, from Mount Sinai's Icahn School of Medicine. And her aim is to help design more patient-friendly clinical research and to ensure recognition of disparities and unmet needs in communities of color. We also have joining our panel, Gary Jacobson, who you heard from earlier today. He was diagnosed in 1998 with a severe case of Crohn's and has been on the cutting edge of pushing for new and more effective treatments and one day for a cure. Gary's worked with the Crohn's and Colitis Foundation as a past president of chapters, a board member, and a layperson of the National Scientific Review Committee, and he continues to work as a patient advocate. For 35 years, Gary worked on Wall Street as a top-ranked equity analyst and portfolio manager focusing on retail, toys, entertainment, footwear, and the consumer sectors, and he's used these skills to help advance the fight against IBD. In primary care, we have on the panel Dr. Duran Schneider, who is right now Vice President of Population Health and Clinical Strategy at Tandem Health. He joined Tandem in June 2020 after spending 23 years in Abingdon Health as a practicing internist, educator, and chief safety and quality officer. And he led that system using the principles and science of high reliability to multiple regional and national recognitions for performance, excellence, quality, and safety. Nationally, Dr. Schneider has been active with the American College of Physicians and is a national faculty member in their quality improvement programs. And then finally, Dr. Janindra Warusavatani, who is a consultant colorectal surgeon who joined St. Mark's Hospital in 2010. He was awarded his PhD in molecular genetics in 2005, and since then has been supervised research students for both MD and PhD degrees in Sydney and in London. He has published many articles in peer-reviewed journals and written book chapters. And he's the lead surgeon for inflammatory bowel diseases at St. Mark's Hospital and is part of the executive team conducting the European Board Qualification for Colorectal Surgery. And he's also the chair of the Education Committee of the ESCP. I'd like to thank the panel for joining us. I'm going to turn off the slide so that everyone can see everyone speaking. And David, I'll let you take it away.
Thank you. Sorry. This is I'm very excited about this because as I mentioned, I really want one of the messages to come out of this meeting is that we really can do better by having a multidisciplinary team to take care of patients with complex perianal disease. And so to sort of frame the discussion, Janindra, you all have this in place at your institution. I would love to hear how it's set up and how it runs.
Okay, so I think a lot of what we heard today was around a significant amount of miscommunication actually between us as clinicians and our patients and all of that. And this was very obvious when Elsa and I started in 2010 and we started seeing patients where we would always see them separately. And that's how we sort of developed the multidisciplinary approach, because especially in perineal Crohn's, there is another issue, which is patients don't have actual access or easy access to when they actually have problems. And from a surgical point of view, it's much better to deal with a situation or a complication quite early on in the piece, so that you don't have to go through this issue of stopping medications because there's a collection and waiting for the surgeon to operate. Those are the sort of major issues that drove us to have a slightly more structured approach to how we deal with these situations. So the first thing and the most important thing is that we started setting up joint clinics so that we would see the patients together, and where possible we would involve an IBD dietitian and an IBD nurse as well. So that's not for every patient, but some of those patients do require a lot of dietetic input. So we've got Gabby, our dietitian, in parallel, and she will come in as needed to help us with the dietary sides of things. And then the next step is also the education part. So the slide that I also showed, which was basically we use very much to classify things, your 2As, 2Bs, 2Cs, so on and so forth. We use that to actually educate where we think we're going to go. But also, it's really important to understand, especially in the patients who are 2Bs, where we know that cure might not be the main issue, is what are the symptoms that are actually driving them to get into trouble. So for some people it's discharge, for some people it's pain, and so on and so forth. And it varies from individual to individual. And then they have to have access into the system when those symptoms start to get worse, so that there is a pathway where they can then either go urgently for an examination under anesthetic, then come back to the clinic or be seen in the clinic, and so on and so forth. So the strategy is that they have then contacts. The way it works for Elsa and myself is they have direct contacts to our secretaries or the IBD nurses, and we've got a helpline available so that if they can't use the helpline or email, there'll be direct contact, and then the IBD nurses will or the secretaries will contact us directly, and then we sort the problem out to get it done without having to wait. Because I don't know how it happens in the American system, but certainly in the NHS, it can be a real mess and people can get missed very easily. So we had to actually structure this to allow to minimize those people that actually got missed and have worsening disease.
That's interesting. So I understand this. So a patient will come and they might see 3-4 providers at the same visit?
That's correct.
Okay. And is there any psychosocial resources that are offered to the patient during that time?
So we don't have psychosocial for that time, but we've got a psychiatrist who sort of deals with a lot of these people, especially in terms of fatigue, pain, and so on and so forth. So usually we will direct them to that person who will then contact them and have systems. So a lot of patients, Elsa and I would often refer them on, suggest, would you like some support? And actually, it's very interesting. There are very few people who say no.
Great. Dr. Schneider, what barriers do you think primary care providers have when trying to take care of patients with complex perianal fistulas?
David, thank you. It's great to be with everybody. I think that if you look at an average primary care panel, we see 2,000, 2,500 patients. So first off is just the frequency upon which we encounter this disease state is not at the level where we see diabetes, hypertension, COPD, heart failure, all the other conditions that we're seeing. So first off, really want to make sure that we put on the table that while we need patient education, certainly ensuring that the PCP understands and is able to best be an advocate for the patient. Making it easier for that primary care doc to be an advocate is one point that I would want to make. And what was just described is amazing, right? I think we're all a little bit blown away by the multidisciplinary nature of that visit. But for us as a primary, at least in the United States, it's quite hard to know where are the centers of excellence. Is my local GI practice, if I'm not next to a university hospital that clearly has and is advertised as a center of excellence, most patients aren't necessarily proximate to a university center. So how can the primaries be in the best position to advocate for our patients and be educated ourselves, not only about the surgical interventions? We don't necessarily need to know that, but we need to know more about the biologics. We need to know more about when patients need immunizations, what role we play versus the GI in immunizing, and then just that last piece about the psychosocial piece. We are absolutely on point for screening for depression, anxiety, and social determinants, and making sure that the left and the right hand are coordinating the overall care plan is something that continues to be a problem. I would just end by saying, or just last comment here, is that we need to get closer to the local practitioners. It's not like the old days when you knew the GI group because you saw them in the hallway, at the cafeteria, et cetera. It is very impersonal. So if you have somebody who has Crohn's, who has such a complicated disease state, helping advocate and getting to know the people that are going to care for that person, is part of what we can do to better be advocates for those patients.
And as far as communicating with the specialist and communicating back with you, what do you like to see? Is it just the office note? Is it a phone call? Is it a combination? And how frequently do you want that to occur?
Yeah, so I guess there's a couple things. Number one is that office notes are great, of course. Having them be templated, having them be really standardized so that we can clearly see what we need to do, separated out versus what the care plan is for others, would be very helpful. That doesn't happen now, where you're the primary, we're expecting the primary to do A, B, and C. We're going to take D, E, and F, right? So office notes are great. They're kind of the basics, but being able to change how we interact with the information that's in those office notes, I think, is key. Just a quick anecdote of what we're building, locally in Philadelphia. We have set up arrangements for HIPAA compliant texting. So we're going back and forth with the specialists using texting, especially when there's urgent issues, and HIPAA compliant texting to the GI office when patients need to be seen urgently. So fast tracking into the local specialists so that we can advocate and actually get our patients in is real world stuff that we're working on here in Philly.
That's neat. Tina and Gary, maybe you can share some of your good and bad experiences along this line with some of the centers that you went to.
Yeah. Tina, you want to go first?
As you wish, Gary. You can start us off. I've spoken a lot.
Okay. I will tell you my biggest frustration with Crohn's disease in general and perianal fistulas, of which I've been plagued for 10 years until the last 3, is that there really isn't a standard of care. I live near New York. I've gone to 3 of the major centers there and have been treated 3 completely different ways by the supposed best in the industry. I've had CTONs, I've had everything that you guys have talked about so far today before I got on at noon. I've had all those treatments. None of them work. What patients want is a path to a cure, a path to getting their lives back, a path to being better, and not even close when it comes to fistulas. A 40% success rate does not excite me. The CTONs I spoke about earlier, I think they're barbaric, frankly. And there are new techniques out there that the FDA seems to want to hold up for some reason, with stem cells, which work beautifully, and your hit rates in the 80-90% range. That is exciting. So it's a very frustrating experience for me as a patient.
I would have to agree with Gary on a lot of this. I live in New York City, have gone to all 3 major centers for my care, and actually had to go to Cleveland and Mayo Clinic to have some of my situations sorted. Everyone treats things differently. I respect that there's multiple opinions and that we can, certainly do our best to have the access to multiple opinions. But I will also just add, I think I've never been offered a psychologist or social worker to address CPF specifically. And even when I have spoken to psychologists, social workers in the space, within the gastroenterology space, I feel like there has been a learning curve to really understand how debilitating and how dehumanizing having a fistula really feels. And, when you speak to a provider outside of the GI space, you often have to explain what this is. And I'll be honest, many of them were horrified, even though they're not supposed to show emotion. And I just want to put that out there. There is a dearth of mental health resources for us as patients. Sorry? There's a dearth of mental health resources for us. And then also the diet approach is just almost, at least has been somewhat non-existent for me. And I'm not sure about Gary's opinion on this, but seeing food particles come through these fistulas and no one guiding me, hey, you might want to consider pureeing your food, or you might want to consider breaking it down into smaller particles, or eating, doing smoothies instead of actually eating whole fruit, because the pain would be extraordinary. I had to learn that on my own. And I think these are approaches that we absolutely need. I will also add one last thing that I don't think gets discussed enough either, is the role of pelvic floor rehabilitation. And many of those patients with perianal fistulas, rectovaginal fistulas, multiple, kinds of fistulae in the genitalia, I don't think that's emphasized enough, how much that can help with chronic pain. And I had to sort of seek that out on my own via my gynecologist, because I was having bladder issues that were sort of left over from having multiple RVF. And so I ended up sort of stumbling upon pelvic floor therapy and realized, a secondary benefit, other than, fixing my overactive bladder, was, helping with a lot of the chronic pain issues, helping with sitting again. I do need to emphasize that with perianal disease is it's tough for us to sit. Planes, trains, on a couch at home. Physical therapy taught me how to sit again, how to walk again, because there was so much pain and bleeding, from the bottom all the time. I don't think that's emphasized enough in the multidisciplinary care sort of practicum here. And I totally agree with everything else that Gary has said too. I would really like to see stem cells come forward. And I was devastated, honestly, in the last few weeks just to see that DARVA didn't meet clinical trial endpoints. I would like to see this come back, and whatever we need to do as patients to help push that forward, even if that means speaking to the FDA, I'd be happy to be involved in. Thank you.
I mean, like Tina, I also had to leave New York to get treatment, and I ended up with Dr. Leitner in Cleveland, who did great things. But the extent of perianal fistulas, I had 7 of them that I lived with for 7 years, and doctors did not have alternatives. I mean, they actually ultimately talked me into getting an ostomy. So I switched little holes for a bigger hole farther up, which had its own set of issues. There needs to be comforting treatments for patients. In my case, my fistulas were so bad and they spread. You talk about vaginal ones. I had one in my scrotum, and no one knew how to deal with that. They brought in a urologist, and he kind of took care of that. And I had multiple surgeons in those surgeries to try to deal with all this stuff. But they really didn't know what to do. I didn't feel confident that they had solutions to this. And you just learn to live with it. In my case, 3 years into fistulas, I just retired. I couldn't get on the train to New York for a 45-minute ride every day. I couldn't sit through meetings. That was the end of my career. And that's very hard. I never thought I'd be putting up as much as my time into seeing doctors and treatments and surgeries and recoveries. And that's why I try to advocate for Crohn's patients and perianal fistulas, and people don't want to talk about them. It's embarrassing, and that stops them also. And then getting doctors who aren't necessarily confident in what they're doing makes it worse. So if anything comes out of this meeting, a standard of care would be wonderful. And what that standard does, fistulas will never cure fistula. I'm sorry, cetons will never cure fistulas. I doubt antibiotics ever will. I doubt the anti-TNFs ever will. 30, 40% hit rates doesn't cut it. So, if there's some way that we could just all get to the FDA and say, hey, it works. Here are all the trials that have been out there. And I know the one that just failed doesn't help, but, there are so many patients out there that need help and they're not getting it. And they're not getting comforted by their doctors either.
So in the interest of time, we have just a couple minutes left. I really would like to hear from both you, Tina and Gary. If you had your magic wand and could design the perfect multidisciplinary complex perianal fistula center, what components would it have?
Great surgeons with stem cells. It would have good gastroenterologists to help get you through that side of it. Nutritionists, because, and I don't care what any of the studies say, every single Crohn's patient's diet is going to be different. There are some things that we all can't eat, and then all of a sudden, nightshades, broccoli, cauliflower, all that stuff don't go near them. Salads don't go near them. But then it's trial and error. I've literally over the years developed what I can eat, which is this big, and what I can't eat, which is this big. And so a nutritionist, I think, is key. And if the person needs it, definitely psych help. It's interesting. You sit in a meeting and you look down, your pants are stained, and what do you do? So, you need help in all these areas. But the first thing that would be in my center is a surgeon who can cure it.
Yeah, I would add to that. Thank you, Gary. Definitely surgeon equipped with stem cells, of course. In addition to that, GIs who have a great understanding, as many of you do today, on perianal disease and sort of working with CRS to really get to the bottom of how to treat this individually by patient. Of course, the mental health component, somebody who really understands the ins and outs of fistulae and the toll that they're taking on patients, and also have the cultural competence to really understand, and the cultural sensitivity to really understand the different issues different racial ethnic communities and also the LGBTQ population might be facing, because we're seeing a lot of issues across these communities. And then the dietitian component, I would add to that a pelvic floor therapist to evaluate if the patient can walk different, get their gait better or get their posture better or be able to sit better, so that we can have better quality of life, because all of these things are it could be affecting our lower back or how we move and be causing pain in different areas. I developed sciatica that was quite debilitating, really needed to be treated by a PT. All of these things sort of go hand in hand. We need to make sure patients are rehabilitated both physically and emotionally sort of at once. And I agree with you, Gary. Being able to refer out to urology, for instance, or gynecology, for some of us, I'm sorry to hear about the scrotal fistula. For me, I was frequenting gynecology and urology. They weren't talking to gastroenterology. And during this time, I had erythema nodosum, pyoderma gangrenosum, hidradenitis suppurativa blowing up. Dermatology wasn't talking to gastroenterology. And it was me managing and coordinating all of it. We need to do a better job to sort of bring in other specialties to really help get the patient the better quality of life that we need.
Great. And then maybe just one last thing, Dr. Snyder, from a primary care physician standpoint, what's the ideal center for you?
Well, first I would want to have transparency. I'd want to have quality measures and other outcomes be available so that, I can understand, is this truly a center of excellence relative to all the other options that I may or may not have? I would want excellent communication with clarity, access, so that if I can get to know those individuals and be able to ensure that there's clear delineation of labor, and then as to what I need to do to best be the primary for that patient. Then the last piece is that, given that the world is moving to value, I would want that center to be accountable for the total cost of care and outcomes for that patient for the year. And that is when we really start to see a frame shift, when there's accountability at that level. And that's the way the world is moving, is for that degree of accountability of that subpopulation across quality, cost, patient experience. And so that would be the perfect trifecta.
Great, that's great. All right, I'll turn it back. That was a really great discussion. I took lots of notes for recommendations, so thank you all for that, and kudos to Elsa and Janindra for what you've all developed as well. Joy and Zoe.
So we're now in the discussion section for this session. And David, as the chair, you're the moderator. So any comments or questions that have been dropped in the chat that we want to address, and any other questions folks have for our panelists, please go ahead.
I'll just take a moment and say that thank everyone. I've learned a ton today. Really, it's been fantastic. And what I've taken away from this is that there are a lot of things where we can improve on the care in this area. Things such as early diagnosis and maybe early screening of patients who are at high risk. Really advocating for the multidisciplinary team that includes many different providers, including dietitians, gastroenterologists, colorectal surgeons, psychologists, social workers, pelvic floor therapists, can really hopefully improve outcomes. There's a tremendous need for patient education, provider education, and tools to do so. And then really advocating for clear conversations and goal setting with patients would be a tremendous step forward as well. So with that, I'll open it up for any additional comments.
I just wanted to add to the, as a caregiver perspective that, and speaking to parents a lot, that even with just a diagnosis of Crohn's or colitis, and they're not at a major center, I've talked to them, and like I talked to them on the other day, and the doctor prescribed, her daughter was diagnosed with like moderate case of Crohn's, and the doctor said, try the specific carbohydrate diet and probiotics. And this wasn't parent initiated. It was, the doctor. And I was like, well, can you ask the doctor these questions? Like, what's the goal of that? I'm not a doctor, but I think that what Tina and Gary said, adding to like what a center would include, I think like the actual patient experience and perspective in a formalized way, that they're part of the team. And so like, if, you're not in a major center, there's even problems with the major centers, as you both pointed out, but and then you have a complication, like my son has, fibrosis, or if you have fistulas, it's like that is even going to be more difficult. And like some doctors don't even think to refer out, and they just say, we don't know what to do. And then if they do refer out or they have to travel, it's like, that's an expense for the family. And, some families can't do that. So if there was a way to get more education to all the GIs who are not, at centers where that's available, I think that's extremely important, like a standard of care.
Stacey, I think it wouldn't be realistic to think that we can improve the level of all centers or a majority of practitioners to recognize early, to treat early, and to make adequate decisions. I think this is not realistic that everyone could do that, but at least here in Spain, there is a strong presence of patient associations identifying centers that can do that. And I don't know which is the situation with in terms of recommendation of practitioners by CCFA, for example, but it sounds to me something more realistic to really identify through medical societies in collaboration with patient associations, centers that not necessarily centers of high excellence, but centers that are in a network, in an adequate network to identify and early treat patients. All patients do not need to be in a university center, but there needs to be adequate connections between practitioners, specialists, and reference centers. And here in Spain, I think that we have quite a good network, and patients had a key role really in making those identifications and referral pathways.
Julian, is there a published list of centers, or is it just word of mouth?
No. I mean, it's public, yeah, and you can go through that and access that through the patient associations. Yeah, it's mainly coordinated by patient associations, but of course, I mean, it has been all of us that are centers of excellence and specialists that have contributed to identify those practitioners and general practitioners, specialists, and centers of excellence where you can get an adequate treatment. I mean, because I'm pretty sure that it is the same everywhere. If you look, for example, at such a small part of the country as Catalonia, which has only 8 million people, there are enormous differences, or there were enormous differences in the quality of care you would get if you live in Barcelona or if you live 150 kilometers away from Barcelona. Okay, and that didn't seem to be okay, and indeed all that started with the Catalan Association, then it spread to the whole Spanish Association, but the identification really of this network that includes everything, not only a listing of centers of reference. This is not really helpful for everybody. It's really the identification of the network involving all players of the healthcare system. All levels, I mean, not all players, all levels of the healthcare system.
I can tell you that I have been on actually a coalition group, and it's called One by One. And we're trying to develop a system and a way to somehow provide multidisciplinary care, not only in centers of excellence and in big universities, but how can we get it to the rural areas and smaller communities? And we actually have a group, the steering committee is members of patients, it's physicians, it's nursing, it's the insurance companies, all the people that would be good stakeholders in this. So we're working on that whole process, and we're going to try and come out with a white paper actually soon. Several of our issues is, you know, telehealth was really great during COVID, and we could reach patients from further distances, as well as they had better access to psychiatrists and dietitians, et cetera. But again, when COVID left the states, you know, it all got shut down and we can't go across lines, which can be a problem because we do get patients from other areas. But it's looking at how do we set up consultations with rural physicians, primary care providers? Or do we start looking at who are the patients that most need this? Is that where we start? And then can we move on from there? So I know Laura, you know, Wingate, you've been, were added on to our team as well. And it's a group of really good stakeholders. So I think watch for the future here. Hopefully we're going to come out with a white paper soon. And this is all the same kind of stuff that we've actually been looking on and investigating as well.
Great. Laura, I think you had your hand up first.
I just wanted to go back to Julian's point about having a place where physicians and nurses and other healthcare professionals are recognized to make it easier for those referrals. And the foundation does have that. We're expanding on it to add badges and other things that will identify multidisciplinary care versus pediatric versus transition. And another thing, very shortly, you know, we're looking at having a fellow of the foundation so that people who've committed their time to the IBD community can be recognized for that contribution, and it will make it easier for patients to find physicians that are, and nurses and psychologists and the whole multidisciplinary team that are supporting the IBD community. So more to come on that, but I do think there's opportunities to expand that and collaborate further across the various organizations.
Tina?
Some great points being made here, and I'm just trying to catch up with the chat. Regarding care coordinators, navigators, patient support groups. So the care coordination, navigation, honestly, Margot, to answer your question, I don't feel like it has been there, not for me at least. It's a lot of it is some stuff that I've had to do on my own. Of course, via patient.
Oh, Tina, you muted yourself, or someone muted you.
Oh, I have no idea how that happened. Regarding patient support groups, I know the Crohn's and Colitis Foundation has one, a Facebook group that I'm helping to moderate. SIA, South Asian IBD Alliance, also has a patient group. We have 1,500 patients and caregivers in our private group, and we do discuss these topics heavily. We also do host live programming. I will say anything related to perianal disease or ostomies may not be attended well initially during the live programming, but the views blow up after the fact because people are watching afterwards so that they can remain anonymous and nobody can know that they're attending. So that's one thing that we have noticed, that these are extremely stigmatized topics. We do need a lot more resources, and we do need to collaborate on that, as was mentioned earlier. I'm just going to make one other point very clear. I don't know how Gary feels about this, but this is such a heavy topic. I remember the first time I spoke about it at Crohn's and Colitis Congress in 2019. I went up to my hotel room and cried. I also cried after AIBD last year. Probably will happen again today. This is a very heavy topic for us patients to be talking about. And I just want to make sure that that's readily understood in this group, and that we are trying our best to make sure that these things are addressed, but it is a huge toll on us to bring even our experiences forward. Thank you for understanding that.
I definitely agree with Tina on those points. It's hard. We're sitting here talking about our tushies and holes in our butts, and it's embarrassing, but I do it because I want to help other people. Also because I don't think doctors really appreciate it from the patient perspective. At the Crohn's and Colitis Foundation, I sat on the National Scientific Review Board for a decade, and I was by far and away the dumbest person in the room, but I gave a great patient perspective that did make a difference in what was funded. So you want to get the patient perspective. Another point I want to make is once you start getting out of the university centers, there's a problem going on with doctors' practices. You have these groups all over the country, these gastro groups and other groups. And as they get acquired by insurance companies and they get acquired by private equity firms, they're cutting back on services. Appointments go from 20 minutes to 15 minutes. The nutritionist disappears. So you're not going to get help outside, any plan that you develop outside of these, major centers, you're not going to get the support in regionally. So that's just something else to think about. Tina, obviously, and I, we manage ourselves. We seek out the doctors. We both ended up outside of New York, in Cleveland. So we have to advocate for yourself. And I saw a study that said 40% of all Crohn's patients really don't go out. They're housebound because they need a bathroom. Add perianal fistulas to that, they're going to drain. It's a mess, and we desperately need help. Not everyone's going to be like Tina and myself, going out there and advocating for ourselves. And Tina, I hope you get better and feel good. And, I've actually had the best year in a decade this past year, health wise, and I'd like to see all patients follow in my footsteps.
Also, we're going to give you the last word.
Well, thank you, Gary and Tina, for everything you've just said. And don't underestimate the strength and the power of what you're saying, and keep going, because I honestly think you are the key to unlock quite a lot of what we've talked about today, actually. So don't underestimate the power of your voice. I mean, one thing we talked about is the scalability of everything. And I think we need to think more creatively about how we can make things like mental health provision scalable, because we've got to think creatively about that. That's going to require another brainstorming session. Some of it's going to be education, but doing what we've been doing for the last decade or so isn't working. So we've got to think about something new for that. And then certainly in the UK for the big picture stuff, the problem we've got is that everything is cancer prioritized at the moment. All the targets in the NHS is all cancer. So the so-called benign diseases just don't get the light of day, which is why, again, Janindra, myself and others, we're at the stage of writing to the government again, just trying to do the very basics, just trying to prioritize IBD. It's as simple as that. And I think probably it's incumbent on us all in our countries just to prioritize these conditions. And it's awful as it's the first step, just to simply say these are important and this has got a massive toll on communities.
So in closing, I just want to say thank you again to everybody. This has been really tremendous. I can't thank you enough. I'll let Amy or Tina have some final words as well.
Dr. Leitner, do you want to go ahead?
No, go ahead.
Okay. I just wanted to thank everybody for joining us here today. I did want to share a slide, if that's okay, that I had put together. Would it be okay to share a slide, Zoe and Joy?
Yes, please.
Let me see if I can pull it up. A second. So, yeah, here we go. I have 2 quick slides that I wanted to go through. So what are some of the key takeaways from today? I think from a patient perspective, and of course, Gary can add more, Stacy can add more from the caregiver perspective, empathy is key. We're going through a lot in this process, really feeling violated by our bodies. And we did discuss a multidisciplinary approach, not to belabor that point, but also, just to have our providers talk to us about some of these sensitive subjects, ask about, the skin tags, fissures, take a look at our bottoms, but also ask about dating, relationships, intimacy. Talk to us about some of the cultural aspects, sexual identity. I realize that there's a lot of cutbacks being made at academic centers, but even if we can get our IBD nurses or physician assistants or APPs to be involved and ask some of these questions, that would be really helpful. Just moving to my last slide here, where do we go from here? I think we need a lot more awareness. And that's why I was really advocating for patient resources. We don't need any more medication ads. We need patient resources. We need open conversation, shared decision making. And we, of course, need better treatments. Gary mentioned to you all that the cetons are a difficult option for us. I'm holding out hope for the stem cells because we do need that greater quality of life. And I do want to emphasize one last point that I know Dr. Adler went into with his presentation is we definitely need a lot more diversity and inclusion in some of these clinical studies. We are seeing higher rates of, perianal fistulae, especially in the African American, even in the Hispanic population, as well as South Asian populations. This has been studied and probably will be studied a lot more in the future. And I think we really need to understand the social determinants of health, yes, but also understand, is this more severe disease, or is this just, time to diagnosis or stigma towards uptake of therapies or even seeking care. So these are some of the things that I wanted to sort of summarize. Thank you all for being a part of this. This does mean a lot to me. I truly believe that we have to be the change that we seek in the world. And I think we have come together to help brainstorm and create that change.
I'm going to add one final thing, Tina, when you said diversity. One thing that the Crohn's, everyone connected to it has forgotten about are the senior citizens. They're not involved in any of the trials. Their bodies are different. They've been taking these drugs and being abused by Crohn's disease for 30, 40, 50 years. When they're in their 60s, 70s, 80s, they need to be treated differently. And no one has looked at any of that. And you throw in perianal fistulas into that mess, it's a nightmare. So don't forget the seniors too. They're a third of the patients. So, and I also want to thank everybody for being here today. as Tina said, we really appreciate all the work that you're doing. So thank you very much.
Amy, you want to say anything, or you good?
I feel like that was a fantastic closure by Tina. So I don't have any words that are really better than that. I'm just very grateful that everyone's here today. And I really appreciate that we're including patients in these discussions, because I think, Tina and Gary's perspective and their voices really should be guiding a lot of what we're doing, because I think a lot of times there's a disconnect between what the provider thinks is important as compared to the patient. So I think it's good to see more engagement at a conference level and then also in these working groups. So I hope that continues, because I think that's really what rounds out the multidisciplinary aspect. We talk about multidisciplinary clinics, but I think that the patient voice in that MDT is really critical.
Yep. Wonderful. Well, thank you all again. Zoe, Joy, any last words?
We have a brief exit survey, if Joy doesn't mind sharing that slide. If you all wouldn't mind taking a moment to fill it out.